Good morning, all. Thank you for joining again our Unicaf Masters Conference. This is the third day of the conference. Today, all the presentations are from the School of Sciences, Health Sciences, Technology and Engineering. We will wait for a few minutes for everybody to join the conference. In the meantime, first of all, the attendees, whatever they want, they can write their comments or questions in the Q&A section. And also for the meantime, until the time that we're going to start at 10, please share with us where are you joining from, which is your country of residence, just to have a geographical diversity of Unicaf's network. All right, I see there are many countries. Ghana, Turkey. Hello, Dr. Papadopoulou.
Good morning, everybody on my end as well. Nice to have you here with us today. I can see that Dr. Cavadia is going through the different countries that we have.
Yeah, we have Kenya, Namibia, Nigeria, Egypt, Barbados, Afghanistan.
I see Guyana. I don't know whether that was mentioned earlier on.
Yeah, at least, but yeah.
Malawi, of course, right? And
Malawi,
Zambia.
Zambia, Botswana, Zimbabwe.
We have from the UK.
Lesotho.
Yes, that's a new one.
South Africa.
I think we've mentioned Afghanistan, right? From Colombia.
Okay.
So we're expanding even further. Yes, to South America as well. Okay. Grenada. Okay. South Sudan, Cameroon.
UK.
Sudan. Sierra Leone.
Jamaica. Philippines.
This is surely a testament of the globalization and, of course, the global outreach of Unicaf at this point.
Ireland.
Yes. Montenegro.
Montenegro, that's true. Mali. Eswatini. Republic of Congo.
Plenty.
Yes.
It is so nice to have you with us, and thank you for joining irrespective of the time, the local time on your end. As I'm pretty sure to some of you it's very early in the morning and to others is very late in the afternoon. So thank you very much for joining. I see from Tanzania. I don't know whether we've mentioned that before.
I think it's time to start our conference today. As we said, today's presentations will be all from the School of Sciences, Health Sciences, Technology and Engineering. Let me welcome Dr. Margarita Olympiou. Dr. Olympiou is the Dean of the school, and she will share with us the opening remarks for today. Dr. Olympiou, the floor is yours. We cannot hear you. No, we cannot hear you.
Now, can you hear me?
Now it's better, but the volume is very low.
How about now?
Doesn't sound very well. It's, yeah.
Dr. Olimpio, can we try to adjust the settings?
I'm trying.
At the bottom left,
Can you hear me now?
it's getting better. Is there a way we can increase a bit the volume, maybe?
Okay, I've tried to maximize it. Can you hear me?
That's great. Thank you.
Thank you. So, a very warm and hearty good morning to everyone joining us today. It is both a privilege and an honor to welcome you to the second Unicaf Masters Conference, an event that brings together brilliant minds from across disciplines to share knowledge, inspire innovation, and foster meaningful connections. For those of you meeting me for the first time, I am Dr. Margarita Olimbiu, Dean of the School of Sciences, Health Sciences, Technology, and Engineering at Unicaf. It is an immense pleasure to stand before you today and to officially open today's sessions. Allow me to begin by expressing my deepest gratitude to all the participants, distinguished speakers, and guests who have taken the time to join us today. I assure you that today's session will be a truly enriching and impactful experience for everyone involved. This conference represents a unique forum for academics, researchers, and practitioners to come together, advancing the frontiers of knowledge, research, and technology for the betterment of humanity. Our aim is not only to highlight the remarkable work being carried out within our community, but also to create an effective platform for dialogue, collaboration, and innovation. Let me take a moment to provide a brief overview of the School of Sciences, Health Sciences, Technology, and Engineering. Currently, the school offers 20 academic programs spanning foundation, undergraduate, and postgraduate levels in fields such as health sciences, computer science, and engineering. Of these, 14 programs are delivered through Unicaf in collaboration with our esteemed UK partners, including the University of South Wales, the University of Suffolk, Liverpool John Moores University, and the University of East London. The remaining 6 programs operate through Unicaf universities in Malawi and Zambia. Additionally, we proudly offer a PhD in public health through the School of Doctoral Studies. For those interested in learning more about our doctoral offerings, I encourage you to attend a dedicated session which will be held tomorrow. Today's session is packed with an impressive and diverse program. We are privileged to feature a series of scientific oral presentations delivered by our talented master's degree candidates, a multilingual and multinational group of scholars who are actively contributing to their respective fields of study. Alongside this, we will hear from 2 esteemed guest speakers, each of whom will share their unique insights and expertise. Today, to have 2 plenary presentations. Dr. Christopher Owens, Senior Lecturer at the University of Suffolk's School of Nursing, Midwifery and Public Health, will introduce us to ripple effects mapping and its applications in public health. Dr. Kezia Njoroge, Senior Lecturer of Health, Public and Allied Health at the Liverpool John Moores University, will discuss the experiences of geophagy among African migrant pregnant women and the implications for public health interventions. This conference has truly become a global platform, bringing together professors, researchers, and scholars to present cutting-edge research and discuss the latest trends in science and technology. This year, we received 42 submissions for oral presentations from our school, and after a rigorous review process, 11 outstanding submissions were selected for inclusion in the proceedings. I extend my heartfelt appreciation to the organizing committee, the chairpersons, the scientific committee, and the editing committee for their tireless efforts in making this conference a reality. Your dedication has ensured a vibrant and thought-provoking program, complemented by the presence of internationally respected speakers. Today's sessions will be expertly chaired by me, Dr. Daphne Kleopa, Dr. Reginald Dennis Guisei, and Mr. Yannis Luga, all being exceptional colleagues and program leaders at Unicaf. Before concluding, I am delighted to announce that the best presentation from each school will be recognized and awarded at the close of the conference. This is a testament to the outstanding work and dedication of our students. Ladies and gentlemen, I wish you all a productive and inspiring conference filled with dynamic discussions and a fruitful exchange of ideas. Together, let us work toward a future defined by groundbreaking knowledge, innovative research, and transformative advancements for humanity. Presenters, the virtual stage is now yours. Embrace it, enjoy it, and shine. Thank you very much.
Thank you very much, Dr. Olympiou. We will move forward to begin session 6. Dr. Daphne Kleopa will chair this session. Dr. Kleopa is program leader of the School of Sciences, Health Sciences, Technology and Engineering. Is Dr. Kleopa with us? We wait for a couple of minutes for Dr. Okay, Dr. Kleopa is here. Can you hear us, Dr. Kleopa? Dr. Kleopa, do you hear me? Good morning. Thank you for being here, and you will chair this session.
Can you hear me? I cannot hear you.
I can hear you. You cannot hear me? Can you hear me, Dr. Kleopa? We'll wait for a couple of minutes to resolve this technical issue with Dr. Kleopa.
I cannot hear the rest of the panel.
Can you hear us now? Dr. Kleopa, can you hear us?
No,
We must wait for a couple of minutes for Dr. Kleopa to be able to join. We must wait for a few minutes. Unfortunately, we face problems usually faced on live events.
Dr. Cavadia, can you hear me?
Yes, Dr. Olivia.
Unfortunately, these things happen in live events. I can proceed with introducing Grace into her presentation until the sound is fixed on Dr. Cleoba's side.
All right, thank you very much.
Grace, are you ready? Can you hear as well?
Yes, ma'am.
Okay. All right. So Grace will present to us today a systematic review of lived experiences of nephrology nurses providing hemodialysis treatment. All right. So Grace, I will let you know when you have 2 minutes left to finish your presentation, and then it will be followed up by 5 minutes Q&A session. All right?
Okay.
Okay. You may start if you start presenting your screen and your presentation.
Okay. Good day, everyone. My name is Grace Cynthia Olofu. This morning, I will be presenting an abstract on a systematic review carried out on lived experiences of nephrology nurses providing hemodialysis treatment. A study submitted to Liverpool John Moores University for a master's degree program. The scope of the presentation will cover the introduction, aims and objectives of the study, the methodology used, results, and then the conclusion. Okay. Excuse me. The kidneys are vital organs in the body with primary functions of 1, to filter excess water and waste products from the body through the urine. 2, to regulate electrolytes concentration in the body, such as potassium and sodium. 3, to produce hormones that are responsible for controlling blood pressure, producing red blood cells, and hormones, vitamin D specifically, that keep the bones strong and healthy. If the kidneys become diseased or for any reason are not working well enough to keep the body healthy, then renal replacement treatment becomes necessary. And there are 3 major types of renal replacement treatment or therapy. We have hemodialysis, we have peritoneal dialysis, and then we have kidney transplantation. Hemodialysis is the commonest form of all kidney replacement therapies. It was first performed in 1924 by a German doctor called Haas. It is a life-saving treatment performed by nephrology nurses on people whose kidneys are no longer healthy enough to perform their functions adequately. According to Bello and colleague in 2022, they documented that hemodialysis accounts for approximately 69% of all kidney replacement therapies and 89% of all forms of dialysis. Hemodialysis is used to replicate the kidney's function of filtering the blood. One, to remove waste and extra fluids, which when the kidneys can no longer do that. Two, to maintain the levels of minerals in the blood. These minerals include potassium, sodium, calcium, and bicarbonate. Okay. In this systematic review, the specialty name nephrology nurse is used to define the group of nurses responsible for caring for patients on hemodialysis treatment. So the role or the functions or the duties they perform, combined with the technological and organizational elements in the hemodialysis work environment, contributes to what inform or make up their unique experiences. The aims and objectives of the study. The study was conducted between August and December 2023. And as part of the requirement for master's program, as I earlier stated, in Liverpool, John Moores University. The objective of the study: hemodialysis as the mainstay in end-stage renal disease management. It requires an organized framework for providing nursing care, technical support, and respite care for patients. This will improve the acceptance of the treatment and enhance the life of people with loss of kidney function. Consequently, there will be less hospitalization and possibility of improved survival rates. Therefore, the main objective in exploring the experiences from the nurse's own perspective is to gain more knowledge and deeper or better understanding of the indispensable experiences of nephrology nurses who provide the treatment. In the same manner, the aim of the study is to explore and describe the subjective experiences of nephrology nurses caring for kidney disease patients on hemodialysis treatment. This is to contribute or create strong evidence base that support nephrology nursing practice. The methodology used. The study systematically reviewed and synthesized qualitative evidence on the experiences of nephrology nurses who provide hemodialysis treatment. Although hemodialysis is the main modality used as a life-sustaining treatment for many people with kidney disease worldwide, it is still a relatively new specialty in nursing practice. However, the impact of nephrology nurses' work in healthcare has revolutionized the management of patients with kidney failure globally. Hence, this study will support the understanding of the experiences of this group of nurses to create strategies that support patients' care and enhance staff well-being. The design used in this study is a qualitative systematic review of studies that are reporting on the experiences of nephrology nurses providing hemodialysis care. While the literature search was conducted using the conventional literature review method based on available electronic data on various internationally recognized electronic databases. There was no defined method for determining the number of studies included in this study. Rather, the guideline of preferred reporting items for systematic reviews and meta-analysis, otherwise known as PRISMA, was used to identify and select eligible studies from peer-reviewed journals. The study setting. Studies were selected based on availability of data from any geographical region and from any setting where hemodialysis is provided, such as inpatient and outpatient hospital facilities of private and public institutions. The studies eligible for inclusion in the review were those that qualitatively investigated nephrology nurses' experiences. Studies that reported the experiences of nephrology nurses whose main focal area of practice is treatment of patients using hemodialysis procedure. Then studies that were published in English language, and articles whose full texts were also available. While the exclusion criteria basically refer to studies considered unsuitable for the purpose of this study, or articles not pertaining to nephrology nurses' experiences in hemodialysis units, such as studies that are conducting secondary analysis, conference abstracts, books, or editorial commentaries. The study participants. The population of interest was mainly nephrology nurses providing hemodialysis treatment. Therefore, the focus was on articles that reported on nephrology nurses' experiences, views, and perceptions of hemodialysis treatment or care. 157 participants from 11 studies across 10 countries were used. These countries are Canada, Australia, Rwanda, South Africa, Mexico, South Korea, Iran, Norway, Jordan, and Indonesia. The quality appraisal or assessment of the studies was undertaken using the Critical Appraisal Skills Program, CASP. It is a standardized quality appraisal technique that offers a structured approach necessary for critically appraising different aspects of a study. All retrieved eligible articles were subjected to assessment process using this CASP qualitative checklist, which consists of the aim of the study, appropriate methodology, proper research design, right recruitment strategy, adequacy in data collection, adequate relationship between participants and researchers, ethical considerations, rigor of data analysis, clear documentations of findings, and overall value of the research. The data extraction. The relevant study characteristics that were extracted include the name of the first author and year of publication, data collection period, and the country in which the study was conducted. Alongside or simultaneously, data regarding hemodialysis nurses' experiences that were considered relevant were also carefully extracted and organized without altering the original text. Data synthesis and analysis. The findings from the studies were clustered into teams and sub-teams, then separately analyzed and reported using thematic analysis of Brown and Clark 2006 as the approach of choice. It has been shown to be appropriate and widely deployed in qualitative research works that seeks to discover meanings using interpretations where the evidence obtained is largely descriptive. The thematic analysis method was considered the most suitable for this study because it closely examined and analyzed the relevant qualitative data to determine common themes from participants' views, opinions, knowledge, experiences, and perceptions. The results. The findings of the review were based on the rigorous analysis and synthesis of data from the 11 studies identified from 10 countries with HD facilities ranging from 1 to 4 units per study, and a total of 157 nephrology nurses participated in the studies selected for the review, with 8 to 55 participants per study. Guided by the research question, relevant data were retrieved, evaluated, synthesized from individual studies, supported with examples in participants' own words, and the findings presented as thematic statements. 4 themes finally emerged from the synthesis of findings from the selected studies. These are therapeutic professional nurse-patient relationship, challenging care organization or care setting, psychosocial experience, and teamwork experience.
Grace, you have 2 minutes remaining.
Okay, I'm concluding. The objective of the systematic review was to explore what is known about the experiences of nephrologic nurses who are providing nursing care to patients reliant on hemodialysis treatment as an effective treatment for patients with kidney disease. Hemodialysis, sorry. As an effective treatment for patients with kidney failure, the clinical use of hemodialysis has become increasingly widespread. The study presented the reality and complexity of care provision as experienced by the nurses responsible for hemodialysis treatment. Understanding these nurses' experiences in hemodialysis care provides insight into nurses' needs for continuous learning and adaptation to changes in technology, treatment options, and patient population. Therefore, it is hoped that increasing knowledge about nurses' experiences regarding the provision of hemodialysis care can highlight opportunities to better support the nurses for best practices and improve quality of hemodialysis treatment that patients receive in the hemodialysis setting. Thank you for listening.
Thank you very much, Grace. And apologies for the technical issues I had before. Your work was very interesting. We have a few questions. Do you have any details on how the quality of care or hemodialysis care was measured in the studies you have identified?
Basically, when you talk about quality of hemodialysis, what they look at is the adequacy of the dialysis received by the patients. And this adequacy of the dialysis just covers the outcome. That is the quality of life of the patient, the avoidance of complications during the session, and the patient generally being able to live as normal as possible. Those are what they use to measure the quality of hemodialysis.
So it was just based on the health outcome. They didn't show any, you did not identify on the studies any specific tools that they measure quality of care, nothing like that?
No, the quality of care relied basically on the quality of life of the patient.
Okay, thank you very much. We have another question from the audience. What do you think is the most important skill a nurse should have to work in the hemodialysis unit?
Please come again. You went off.
What do you think is the most important skill a nurse should have to work in the hemodialysis unit?
It's the first theme of the results I got, which is the relationship between the nurse and the patient, because all other activities in the unit depends on this relationship, which will influence the patient's attitude to the treatment, the patient's acceptance of the treatment, even when they are out of the dialysis facilities. So it's interpersonal relationship is a skill, the most required skill for the nurse in hemodialysis unit.
Okay, and the last question. Can you mention some of the challenges that the nurses experience on the care unit?
Yes, from the study, they have resource constraints. They have moral distress, that is, at a contact and prolonged relationship where a patient comes in, they spend 4 hours, 2-3 hours minimum, and they come in 3 times a week, and you spend time over time, they become bonded, and sometimes these patients become more like a family member to them. And gradually, as the patient's condition deteriorates, emotional attachment, and then there's emotional distress. Apart from that, overwork, shortage of staff, lack of consumables sometimes. So these are things that form challenges in the unit for most of the nurses from the studies.
Thank you. We have another question. Your study covered a wide geographic area. I'm not sure how the experience and training varied from different areas. Did you try to understand the variables between different regions?
Please come again. I didn't pick the question.
Did you try to understand the different variables or experiences that the nurses had between different regions?
Yes. Actually, it's part of the recommendations, which I did not present in this abstract, that the studies, as much as most of the findings can be generalized, so many other things are based on the race, the culture, the country. So definitely there are differences. But basically, the environment, the setting of operation, hemodialysis is the same all over. So, but where culture or racial issues come in, then I will advise that that will be taken into consideration in whatever setting the dialysis is being performed.
Okay, thank you very much, Grace, for your work. We will move forward to the next presentation, which is will be delivered by the student Ayodeji Daniel Ahemba-Michi. The topic is, has the prevention of mother-to-child transmission services offered to HIV-positive pregnant women been effective in the prevention of mother-to-child transmission of HIV in Nigeria? It is a systematic literature review. Hi, Ayodeji. The floor is yours. As you remember, you have 15 minutes for the presentation and 5 minutes for questions. You may share your screen now with us.
Good morning.
Good morning.
Okay, it may not be morning for everybody. All right. My name is Dr. Ayodeji Oyebamiji Daniel, and I'll be presenting a systematic literature review, which was part of my submission for a master's degree with the University of Suffolk. And the title of the presentation is the question, are PMTCT services offered to HIV positive pregnant women effective in the prevention of mother-to-child transmission of HIV in Nigeria? Right. So by way of introduction, mother-to-child transmission of HIV accounts for 90% of new HIV infections in children globally. This according to the Koch and colleagues. PMTCT, which stands for the Prevention of Mother-to-Child Transmission of HIV, helps to reduce the overall burden on our healthcare systems and promote stronger health systems in line with SDG 3.8, which talks about the provision of universal healthcare to all people by 2030. According to the United Nations UNAIDS 2021, Nigeria is the largest contributor out of 7 countries, which accounts for half of the global number of children newly infected with HIV. So this gives us an idea of the burden of what we're talking about, the burden of the disease. Factors that contribute to this burden includes poor PMTCT facilities, inadequate access to healthcare, insufficient disease awareness, and cultural barriers, which also includes stigmatization and things that make it difficult for people to actually identify themselves as HIV positive or come for HIV positive antenatal clinics for PMTCT services. All right, the aim and objectives of this research are as follows. The research question that I sought to answer through this review is, are PMTCT services offered to HIV positive pregnant women effective in preventing mother-to-child transmission of HIV in Nigeria? Because I'm based in Nigeria, quite interested in this particular research. The aim is to determine if PMTCT programs in Nigeria have been effective. And I use the PICO acronym to develop the question. P stands for population, I stands for intervention, C stands for the comparator, and O stands for the outcome. And the objectives of this systematic literature review are as follows. Number 1 is to examine if mother-to-child transmission rates across Nigeria, and to examine the trend of these rates over the years from studies within the last 10 years. And then also to identify challenges to prevention of mother-to-child transmission of HIV in Nigeria and make relevant recommendations. This is the methodology for the study design, and the search strategy. I used the PRISMA guide, which stands for the preferred reporting items for systematic reviews and meta-analysis. I used it to screen and select the studies that were included in this review. 3 databases were searched. The systematic search of 3 databases was conducted on the 12th of August, and the databases that were searched were the Nursing and Allied Health database, the Public Health database, and the Health and Medical Collection, and all of them were searched under the ProQuest Central database that was made available to us through Unicaf. A search was also carried out on google.com and elicit.org using the research questions in order to retrieve additional articles. All the available studies were published within the last 10 years, which is from 2013 to 2023, and they assessed the rate of mother-to-child transmission of HIV in the Nigerian public health centers, and the associated factors were also included. There was no discrimination as to the timing of HIV infant testing. It ranged from birth to 18 months. So some of them tested at birth using dry blood tests. Some of them tested at 18 months using a PCR, polymerase chain reaction test. Reports were excluded using the ProQuest exclusion tool. And if the full text of the report was not retrievable, it was excluded. If the article was not peer-reviewed, it was excluded. If it was not a primarily Nigerian study, or if it was a qualitative study, it was also excluded. So those were my exclusion criteria. And these are my search terms. I may not need to read through everything. but these are the search terms that I used to search on the ProQuest database and also on google.com and elicit.org. Data extraction and analysis type. My data extraction was done using a Microsoft Excel data extraction form. And then the information that was extracted from all the studies included the author of the studies, the year of publication, period covered by the study, title of the study, study design, study area, sample size, aims of the study, the interventions carried out, and the study outcomes. And the main outcomes that were being measured were the mother-to-child transmission rates of the mother-to-child pairs using the dry blood test or the DNA, PCR, polymerase chain reaction tests. Narrative synthesis was done due to the heterogeneity of the data in the selected studies, and the studies were subgrouped into geopolitical zones. Nigeria is divided basically into North and South, and the Northern Nigeria has three geopolitical zones. We have the Northwest, the Northeast, and the North Central. Southern Nigeria has three geopolitical zones as well. We have the Southeast, the Southwest, and the South-South. So the studies were subgrouped into these geopolitical zones. And the studies that came before 2014 were also studied to see what the trend was before 2014 and after 2014 to see if there has been a significant improvement in MTCT rates across those periods of time. So the results that we got from getting these studies from our PRISMA guidelines. We got 3 studies. I got 3 studies which were retrieved from the ProQuest central database, and 2 studies that were retrieved from elicit.org. There were 7 studies that were retrieved from google.com. So this gave me a total of 12 studies which were included in this narrative synthesis. And all the 12 included studies were critically appraised using a critical appraisal tool by Joanna Briggs Institute. The tool contains 9 criteria, and it is really giving a score of 1 or 0 based on whether the answer is yes or no. So 7 to 9 is low risk, 6 to 4 is medium risk, and 0 to 3 is high risk. So that was the appraisal tool that was used to critically appraise this particular study. The components of the appraisal includes a sample frame, sample population representativeness, sample size, sampling method, reporting of the subject's characteristics, data analysis coverage, the method of measurements or diagnosis, the appropriateness of the statistical analysis, and the response rate. So those were the 9 items that were used on the critical appraisal tool. All right. So 6 studies out of the 12 studies were from Northern Nigeria, and they are as listed here. There was 1 study in the Northwest, 2 studies in the Northeast, and 3 studies in the North Central. The studies were from Southern Nigeria. There were 2 studies from the Southwest, 1 study in the Southeast, and 1 study in the South-South. And then 2 studies out of the 12 actually cut across both the Northern and the Southern regions. The major intervention in most of the studies was the provision of PMTCT services, which consisted of the administration of antiretroviral therapy, which could be single, double, or triple therapy, to HIV-positive pregnant women throughout their antenatal care, a short course of nevirapine and cotrimoxazole prophylaxis to the baby, and a follow-up and HIV testing of the child, either at birth with the dry blood test, spot test, or between 6 weeks and 18 months with the DNA PCR test. The outcomes of the studies were as follows. 9 out of the 12 studies reported MTCT rates.
Ayodeji, you have 2 minutes left. You have 2 minutes left. Yeah, you can conclude.
I'll soon be through. Yeah. So 9 out of the 12 studies reported MCCC rates for mother-to-child peers. The combined sample size of all 9 studies was 25,150, and the weighted average MCCC rate of all the 9 studies was 2.9%. Northwest had 4.7%, Northeast 4.7%, North Central 2.7%, Southwest 1.4%, and Southeast 0%. The MCCC rate for Northern Nigeria was 3.7 compared to 1.1 for Southern Nigeria. And the MCCC rate for periods before 2004, between 2004 and 2014, was 3% compared to 2.8% for studies covering periods from 2014 to 2020. So this simply means that the MCCC rate of Nigeria, based on the studies published between the last 10 years, is 2.9%, which is lower than the current global average of 11%, and is within the required less than 5% for breastfeeding countries, according to UNICEF. And it also shows that the MCCC rate of HIV is higher in northern Nigeria than southern Nigeria, and many factors can be responsible for that, including missed opportunities for PMTCT, religious beliefs and rural settlements, low uptake of PMTCT services, poor PMTCT facilities, economic and educational inequalities. And all right, so this is also talking about the factors and then some of the things that were actually done during the PMTCT services, the triple ARV regimen, and the nevirapine prophylaxis given to exposed babies. So these are my recommendations. According to Schneider et al., since 2010, funding for HIV/AIDS intervention programs by international bodies has not increased. So in order to facilitate the achievement of SDG 3, international bodies such as the Joint United Nations Program on HIV/AIDS, the World Health Organization, and the Global Fund should allocate more resources to funding programs that revolve around HIV testing. UNICEF can also work in conjunction with local NGOs in Nigeria to educate the public about PMTCT. And a combination of this collaborative action between these international bodies, regional and local NGOs, and the national governments will help in the actualization of the goal to totally eliminate mother-to-child transmission of HIV in Nigeria by the year 2030. So this is the conclusion. This is like a summary of everything that I've said. For my study, the national MCCT rate is 2.9%, which is less than the global average, and it is lesser in southern Nigeria than northern Nigeria. More studies need to be carried out, though, to determine associated factors for MCCT of HIV, especially in northern Nigeria. Thank you.
Thank you, Ayodeji. Do we have any questions from the audience? Okay. There are no questions from the audience. Can you highlight the conclusions again? I mean, can you just say a sentence as a conclusion from this systematic review you have done?
So the systematic review actually shows that PMTCT services has actually been effective in Nigeria over the last 10 years. Even though the studies that were taken were published within the last 10 years, but they actually cover a period from 2004 to 2023. But looking at the progression, we can see that MTCT rates were actually lesser after 2014 than before 2014, which shows a significant progress has been made. And comparing it to the global average of 11%, the MCT rate of Nigeria currently is at 2.9%, which shows that significant progress has actually been made in reducing the prevention of in preventing mother-to-child transmission of HIV in Nigeria through antenatal services.
Okay, thank you very much, Ayodeji. We're moving forward to the next presentation, which will be carried out from Shaima Ahmed Abdel Mahmoud Abdel Monaim. The presentation will be about the negative outcomes of the CO2 exposure during pregnancy on maternal and fetal health.
Good morning, doctor.
Good morning, Shema. The floor is yours. You're ready to start your presentation. You can share your screen.
Can you share my presentation, doctor?
Yes, we can see your presentation. If you can make full screen, that's great.
Okay.
And you can start now. Yes.
Good morning, everyone. I am Shaima Ahmed, a clinical pharmacist from Egypt, and today I will present with you my study to get a master's degree from Liverpool, John Maurice University, and Unicaf. My study was a scoping review on the negative outcomes of sulfur dioxide exposure during pregnancy on maternal and fetal health. Currently, could you flip? Let's talk about the introduction. Air pollution is a pervasive threat to both health and the environment. More than 99% of the global population resides where air pollution exceeds the WHO air quality guidelines, resulting in 4 millions, more than 4 million deaths annually. The most concerning pollutants in terms of public health impact include the PM or particulate matter, carbon monoxide, ozone, nitrogen dioxide, and sulfur dioxide. Kindly the next slide, please. For maternal health, WHO defined maternal health as the state of women's health during conception, gestation, and the postpartum period. Developing maternal health, one of the WHO priorities based on human rights perspective and connected to innovatives for universal health coverage. Problem might arise at any point during the gestational cycle, which could have an impact on the maternal, the toddlers, their perinatal, postnatal, or fetal health. We here want to take a focus on the SCT3 goal that ensure healthy lives and promote well-being for all ages. So,
Excuse me, Shaima. Sorry, I'm interrupting. Can you move your mouth a bit further from the microphone because we cannot really hear you clear?
okay, this is good or bad?
Yes, that's better. Thank you very much. You can
Okay,
continue.
thank you. Okay, we will focus now on one target or two targets of the SD3 goal, a sustainable development goal 3 that ensure healthy life and promote well-being for all ages. WHO target to decrease maternal mortality to less than 70 per 100,000 live persons and to decrease the mortality of neonatal less than 5 years old as low as 25 per 1,000 live persons. Next slide, please. Sulfur dioxide gas, which is a one concern of public health. There are two sources of SO2 emissions, natural source and human-made source. A release of significant amount of SO2 source into the atmosphere from a volcanic emission can contribute to acid rain, which contribute to asthma in adults and children. SO2 can cause irritation also to respiratory system, and the increased rate of urbanization and the industrialization has raised the SO2 emissions. Even now, we have limited studies that link the exposure of SO2 emissions during pregnancy with negative outcomes on maternal and fetal health. Next slide, please. So the aims of my study were investigating the negative outcomes of SO2 exposure during pregnancy and maternal and fetal health. The second aim was identifying the public health issues related to the negative outcomes of SO2 exposure during pregnancy on maternal and fetal health. And the last aim was proposing solution to overcome the public health issues related to negative outcomes of sulfur dioxide exposure, sulfur dioxide gas exposure during pregnancy on maternal and fetal health. Next slide, please. To make this study, I used a scoring review, which is unlike systematic review, no need for critical appraisal. I have to identify the question, the research question, making a search strategy that depends on a match system research and putting strict inclusion and inclusion criteria, and finally screening data. Next slide, please. To make the question of the study, I used a BCC question strategy that I have to identify population that were pregnant women and fetus. The concept was the negative health outcome, and the context that was the S2O exposure during the pregnancy. Next slide, please. To make a comprehensive research, I put next a subsequent questions that where I have to identify the sources of SO2 emission, the influence of temperature, what are the determinants of health of pregnant women, what is the relationship between the duration of pregnancy and the negative outcome, and finally, what is the relationship between the place and the negative outcomes. Next slide, please. I used PubMed, Scopus, and the Web of Science database searching. Searching was depending on a meshing system. I used a mixed word from SO2, sulfur dioxide, written in English Britain and American Britain, and I used the word exposure, word units, and I make a mixed word to find the relative literatures. The record were 576 literature, but my inclusion criteria not restricted to a geographical specific geographical place, but restricted to a time between the 1st of January 2014 and the last of December 2023, approximately 10 years. And I excluded all duplicates and not available full text. Animal studies, in vitro studies, primary articles, not I included the primary articles, but excluded the secondary articles like systematic reviews, meta-analysis. I focused on time analysis, court study, case control study, and also exclude all the literature that doesn't give a direct relationship or health outcome. And finally, I reached to 37 studies with the eligible criteria and included in this scoping review. Next slide, please. Result, what we have observed that in mother, there is negative health outcomes ranges from abortion to gestational hypertension and gestational diabetes, including premature rupture of membrane and preterm premature rupture of membrane. The difference between them is the PPROM is before 57 weeks.
But Shaima, you have 2 minutes left.
Okay, and for the neonatal, lifelong limb defect and lifelong side effect. Next slide, please. Difference, human-made force is more than natural force. The influence of temperature is controversial. A determinant of health like psychoeconomic and nature of work residency not well mentioned. Most reported outcome in the first trimester, and 36 of 37 studies included were in heavy industrial polluted places, mostly in China. Next slide, please. Exposure to heavily industrial SO2 emission is often constant, more chronic, and acute CO2 continuous exposure consequences are more intense and harmful compared to those caused by natural SO2 gas emission of SO2 gas, cooling gas, no explanation was put to clarify the effect of temperature. Organs of fetus developed at different times during pregnancy affected by the exposure of SO2 gas. Psychoeconomic factors like work, monthly income have negative have greatly affect negative health outcome of SO2 exposure. Next slide, please. What are the
May
consequences
I
of
ask you
negative
to
health?
conclude? Shema, may I ask you to just give us a sentence for conclusion?
Conclusion that SO2 exposure during pregnancy can lead to fatal serious health outcome like increased mortality and hospital admission. To solve this problem, we have to provide health equality, increase universal health coverage, increase the role of government like making policies, increasing and increase the awareness through participation of all communities in environmental and decision making. Thank you.
Okay, thank you very much. May I ask again, you move your mouth away from the microphone for Q&A, and may I ask if it's possible you open your camera?
I'm sorry, my
Turn
camera
on.
isn't work. My camera isn't working well. I'm sorry, my camera isn't working well.
Okay, so we have some questions from the audience. Thank you for your presentation, Shaiman. Did instance whether an access matter with relevance to exposure and point sources of sulfur dioxide? If so, what have been your observations from your study?
Please again, the question.
If distance, whether an access matter with relevance to exposure and point sources of sulfur dioxide, and if so, what have been your observations in your study?
Observation are different from effect on mother and the effect of their infant, and there is no study investigate that the effect of SO2 exposure on both. Some studies searched for effect on mother and others effects on infant, and there is not well studied effect.
Okay, the next question is, how did the cost of dialysis affect your work as a specialist nurse for dialysis patients? Since most hospitals don't have dialysis machines, what is your comment on this?
I am not working on dialysis.
Yes. How did the cost of dialysis affect your work? Since there are no machines in the hospitals.
No, I am not working on dialysis. I am working on sulfur dioxide. This question is for the first presentation.
Yes, apologies, that was my mistake.
Not a problem.
Okay, is there any sensitization campaigns as regards to the effect of sulfur dioxide exposition, especially to the populace in your area?
Yes, all the studies that reported the side effect on infants and the mother were in industrial parts of China, heavy polluted parts, and their communities were very poor. Their houses were near the factories, not in modern areas or in green areas. They were all living in besides the factories or working as the workers in the factory.
Okay, last question. For respiratory disease, does it affect both mother and fetus or mother and child after birth?
Both. SO2 sulfur dioxide exposure can cause abortion or cause a left defect or special defect can the infant really want healthcare long life. But for the mother is a period of time like gestational diabetes, not long life diabetes, gestational hypertension, not long life hypertension. But in their infant can be negative outcomes long life, like orofacial defect, neurological problems, congenital decline, and the other side effects.
Okay, thank you very much, Shaima. It was a very good presentation. We're moving forward to the next
Thank you.
student. Thank you, which was Ama Ohenewa. She will present us a scoping review of HIV testing approaches in Ghana, trends, effectiveness, and challenges.
Hello, everyone. Can you see me?
Yes, I am. We can see you, we can hear you. The floor is yours. You may start. You have 15 minutes for your
15
presentation
minutes.
and 5 minutes for Q&A questions.
Okay.
Q&A. Thank you.
Okay. So, can you see my slides?
Yes, we can see your slides. You may want to have a full screen.
Okay. So, my name is Ama Ohenewa from Ghana, and I'm presenting today on a scoping review of HIV testing approaches in Ghana. And particularly, we'll be looking at the trends, effectiveness, and challenges. This is my outline for today. HIV testing is very crucial for HIV prevention, care, and treatment. And it has been a recurring global concern, especially in sub-Saharan Africa over the years. Now, in a quest to combat HIV, many countries have adopted some approaches, and Ghana is no exception in order to reduce its prevalence. We have adopted quite a number that includes the VCT, that is the voluntary counseling and testing, which is also the same as the CITC, that is client-initiated testing and counseling. We have the PITC, provider-initiated testing counseling, then the FBIT, that is the family-based index testing. We have outreach programs, mobile clinics or mobile testing, and then self-testing. Now, the aim of this whole project was to assess the various HIV testing approaches that Ghana has employed, and also to assess its effectiveness over the period in her quest to combat the disease. So objectively, we had tried to identify and then summarize the various testing approaches, look out for the advancements or changes that are taking place, and also assess its effectiveness as well as challenges with regards to the various employee testing approaches over the years. Now, with the method, a comprehensive search, strategy was employed. I went through quite a number of databases such as PubMed, Embase, Scopus, Google Scholars, yes, just to get all the available papers or research articles there. And yes, so I was interested in articles written within the time frame of 2005 to 2024. That is roughly a period of 20 years. The reason is that I wanted to inculcate the Millennial Developmental Goals and then the Sustainable Development Goals, within that. I'm proud to that. I mean, another reason also is that prior to those years, not much had been written in Ghana with regards to HIV testing approaches. Yes, and averagely, I realized that the average age of a document is about 6.9, which indicates a relatively, recent focus on the topic. Yeah, so a 5-stage framework was followed And I ensured that all these articles actually were in line with my research questions. I had 3 research questions for this paper, and they are that's I wanted to know what the various HIV testing approaches employed in Ghana over the years were, and then how HIV testing approaches in Ghana have evolved, advanced, and also been changed over time. And then lastly, I wanted to know the effectiveness and challenges. So I ensured that all these articles that I had at hand followed this research or answered these review questions for me. And at the end of the day, 50 studies were included in my search. Now, this is a Prisma chart showing how I came about this whole thing. I started with about 1,866 papers, and we ended up with just 50. Of course, where I had to include and make sure that the articles were written in English, they were about Ghana in particular, not generally Africa, but Ghana in particular. Yeah. So the inclusion and exclusion criteria, I employ the PCC framework, and the P stands for population, C for concept, and the last C for context. For the population, like I said, the focus was in Ghana. So I took into consideration the Ghanaian population, both old and young, male, female, everyone was inclusive. Then with the concept, I was looking at the testing, the various HIV testing approaches in Ghana, the VCT, PITC, self-care, self-testing, and then the FBI team. Then with the context, as I explained earlier, I looked at the time frame between January 2005 and 2024. Yes, so there was a significant advancement. As I continue with my search, I got to know that Ghana had employed quite a number of the testing approaches, and it initially started with the VCT, that is the voluntary counseling testing, where clients volunteered. They volunteered to have the test done after being educated. Yes, then it moved on to the PITC, which is the provider-initiated testing and counseling. So with this one, the healthcare provider, recommended the test based on the signs and symptoms the client presented with. And as time progressed, it was later inculcated into the antenatal care. So currently, you realize that every pregnant woman would have to go through this test, but that was how it started. The provider or the healthcare providers would just make the suggestions based on the symptoms and signs clients presented. And it was very good. That was the progress. Then we had the FBIT, the family-based index testing. So when a client came around to have the test done and then found out he or she was positive, after much education, this client volunteers to, involve or call the loved ones. It could be the sexual partners and families or relatives close that this person has this close bond with, so that they also got tested to find out whether or not they were also positive. So that also helped because they willingly decided to involve their families or loved ones. Then the mobile testing clinics, that approach was very, very important, or it came in handy for people who were in the areas which were hard to reach in Ghana, the hinterlands, those which were at the very far areas, rural areas of the country. So with us, we have everything on a wheel. They visited all those places to engage them and also give them the opportunity to test. Then with regards to the self-testing was actually the best or the preferred approach for people who preferred privacy. And funny enough, it was most of the people in the target group, the key population, they preferred this. When I say key population, I mean men who have sex with men, the MSM, then the female sex workers, they also prefer the self-testing because they wanted their own privacy. Yes. with regards to the effectiveness, it was seen from the papers that I went through that quite a number of healthcare facilities enrolled on the national program. And this was very good because they could relay all the data and everything that was needed, into the national pool for further researches and further implementation. So that was one thing that was observed. And also realized that the willingness of the Ghanaian population to partake in any of the testing approaches was quite alarming. I mean, it was interesting. They showed interest to, patronize any of the approaches. And also the one effect was that it's caused, there was an improved linkage to care and treatment. What I mean by that is that once you were tested positive, you weren't left on your own. You were placed on medication, after the viral load treatment and then the early infant diagnosis and everything, you were enrolled on the national treatment scheme so that you would be taking your medication, and also that too improved. And again, we realized that there was a reduced the high prevalence among some target group, especially like the female sex workers, actually became lower as compared to previous surveys. Yeah. Now, with the challenge, stigma and discrimination still remain the major challenges to, the testing approaches in Ghana. The reason is in this part of the country or in this part of the world, there is this misconception that every HIV
you have 2 minutes left to conclude.
Okay. So yes, they have this perception that people who have HIV live promiscuous lives, and also there is a strong stigma and discrimination. So as a result, not everyone, though there is that willingness to test, the implementation of that willingness is actually very suboptimal. They don't really want to come out to do the test. And also there's constraints on resources. Like I said, in the hinterlands, some of the facilities are not disability friendly. They don't have a lot, though we have the viral load treatment and all, they are in limited numbers. So sometimes those in the rural areas do not have access to all of that. And it's a challenge. With regards to geographic and social demographic disparities, we get to know that those in the rural areas were more willing to enjoy or to participate in any of the testing approaches as compared to those in the cities. And again, realize that the educational level of some of the junior high school youth, because they had this negative perception about this whole testing thing. So I think with that, if an age-appropriate intervention is brought in, it will be able to help them. Yes, and overall, those in the females were more willing to have this test done as compared to the males. So overall, we have this review actually have highlighted the progress Ghana has made, using the various testing approaches, and also it has made us know that there is more work to do, yes, in regards to targeting the challenges, especially the stigma and discrimination, the social demographic disparities and everything, just in order to make Ghana a better place. So this research is this review is very paramount for Ghana's HIV response, and it provides a solid foundation for evidence-based decision-making and intervention development. Thank you. These are my references.
Thank you very much, Anna. A very informative presentation. We have some questions from the audience. How do people come to terms with the results of testing positive or negative? And are there any extreme cases as regard to this in Ghana?
Please come again.
How do people come in terms with the results of testing positive or negative? And are there any extreme cases as regards to this in Ghana?
So usually they are pre-cancelled before the test. So the clients are sensitized as to whether the result will come out negative or positive. They are made aware that it won't kill them. And there are ways that are, there are some measures put in place to help them through should they come out positive. So that is not an issue at all.
Okay, thank you very much. Another question is, HIV prevalence rate in Ghana has recently heightened, especially in the Ashanti and eastern regions of Ghana. Can we link these several testing approaches to this development?
Sorry, I really didn't hear you.
HIV prevalence rate in Ghana has recently heightened, especially in the Ashanti and eastern regions of Ghana. Can we link these several testing approaches to this development?
How do we link? Okay, so
if we can link these several testing approaches to this development.
yes. So with these two regions that you mentioned, the Ashanti and then the Eastern, we realize that most of the people there are in the rural or the hard to reach areas. Yes. So like I said, with constant education, we need to educate them more. We need to educate them more so that we employ all these approaches. We can employ all these approaches, and also include education, sensitizing them on the need to protect themselves and also get tested in order to know their status. Yeah, so that the prevalence can come down. Yeah.
Okay. What are the measures in place to mitigate the spread of HIV?
Yes, the measures put in place. Currently, we are is the awareness. Still move from place to place, educating people on how important it is to get tested. And also when you have the testing done, on what to do so you don't go about spreading the disease. So currently that is what is ongoing. It's just the awareness, creating awareness on all social media, on TV stations, radios, community, using the chiefs and community leaders and all to make this announcement.
Okay, another question, how readily available are self-testing kits in Ghana?
Yes, so as a social demographic disparity, it is more common in the urban areas as compared to the rural areas. So when you walk into any government facility, you would have access to the self-testing kits.
Okay, and another question, what is the rate of stigma of people against HIV patients in Ghana and even those coming for voluntary testing?
Yes, so again, social disparities come in here. With those in the urban areas, it's actually not a big deal. Yes, if you are positive, the stigma is quite low as compared to those in the rural areas where everyone knows something about the other person. More like you are an open book, everyone knows everything about the other. So it is in such areas that the stigma is really heightened, and education is still ongoing, trying to let them know. As I earlier said, that they have this perception that once you're HIV positive, it means you led a promiscuous life, which is wrong. So once that has been debunked or they've actually been desensitized of that mentality, things will be fine.
Okay, and last question, is there any role played by government in these interventions?
Yes, please. So we have volunteers, the youth especially, who volunteer to go to those hinterlands because some have to go by water. It's difficult fishing those places. But then people have volunteered to go there, yes, and they go speak the language of the people, educate them, eat with them, try and be with them so that they understand they are there for their good. So sensitization is still ongoing, and hopefully in the next few years, the prevalence should reduce drastically.
Okay, we have another question. which I think is important. Is there adherence issues or loss to follow-up, especially for population with mobile testing? If yes, what should you recommend as ways to mitigate it?
It's quite a lengthy question. Can you come again?
Is there adherence issues or loss to follow-up, especially for population with mobile testing? If yes, what should you recommend as ways to mitigate it?
Okay, so yes, I think with their mobile testing, they have their schedule. So should they visit a community today or for this period of month? Let's say they spend a month in this community, they visit it again in the course of the year for follow-up and everything. So it's not a one-time thing. And so their data or the information they gather is not lost. They revisit the place from time to time. So it's safe.
Okay, thank you very much, Emma, for this informative presentation and the Q&A.
You're welcome.
Thank you. We're moving forward to the next student, which is Nuran Nasser Najeb Nars Mohammed. The research is about the use of whole genome sequencing techniques for the surveillance of antimicrobial resistance in escape bacteria, opportunities and challenges. It's a scoping review.
Hi.
Hi, Nuran.
Hi, doctor. How are you doing? Let me just share my screen.
Yes. You may start. You have 15 minutes for presentation and 5 minutes for Q&A.
Okay, so hi, my name is Nuran Nasser, and this dissertation was submitted as a requirement for the fulfillment of the master's degree in international public health from Liverpool John Moores University. The title of this presentation is the use of whole genome sequencing techniques for the surveillance of antimicrobial resistance in escape bacteria. So this is the outline that we're going to follow. So as an introduction, we're going to talk about antimicrobial resistance, which is something that occurs when pathogens or infectious agents can no longer be killed or stopped by agents that used to stop them. It is agreed upon that antimicrobial resistance is generally a result of the overuse and misuse of antimicrobial agents, and it is a human-caused issue. It has an impact on the economic performance of countries, as well as several of the UN Sustainable Development Goals, specifically SDG 1, as with higher rates of antimicrobial resistance, it will affect the poverty rates. It will affect also food security, which is SDG 2, by having like an impact on cattle production and meat production. And finally, obviously, SDG 3, which is the good health and well-being, it will be impacted if we have bacteria or infections that we cannot treat. Additionally, we decided to focus in this review on escape bacteria. These are Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter baumannii, and Pseudomonas aeruginosa, and finally Enterobacter species. I chose these species specifically because they are highly represented in resistant nosocomial infections or hospital-based infections. They are present in different environments, and they contain many antimicrobial resistant genes, and they do display phenotypic antimicrobial resistance, meaning you can test what they resist in the lab easily. So basically, in the traditional way, surveillance for antimicrobial resistance was basically we would wait for an outbreak, and then we would have like a list of patients, wait until we have multiple cases with the same indicator organisms, and then we would do an investigation, and then we would come to having like the results or actions that we can come and contain further spread. On the opposing end, if we do routine sequencing of nosocomial infections, for example, we can predict or have like a predictive value for what actions to do in case there is a high chance or a possible or low chance of an outbreak based on these genetic markers. So it does overcome the drawbacks of current standard of testing or for AMR surveillance, which is waiting and then doing the phenotypic susceptibility testing of the microbe that is suspected. So in this review, the aim was basically to examine the usability of whole genome sequencing for AMR surveillance and the potential impact it might have on understanding the problem and providing possible solutions to it. We tried to answer some research questions, which is basically like how much do people use whole genome sequencing in AMR surveillance, specifically in escape pathogens, and where do they mostly do that? What factors affect this distribution? What are the techniques? What are the bioinformatics tools that they use? Why do they use these specific tools, and do they have limitations of their own? And finally, what are the public health implications and future directions that we can take based on the findings of the previous questions? So the methodology for this review, it was a PRISMA-based scoping review. We did have a very broad search strategy to allow the collection of as much data as possible. I had some inclusion criteria, which the study had to use the whole genome sequencing to determine AMR patterns. The techniques that were used to screen both chromosomal and plasmid DNA. It had to have multiple samples of a single pathogen or multiple pathogens, and all study designs were included. I did not have a limitation on study type or study design. We excluded studies that focused on non-escape pathogens. Anything that worked with a single sample was not available in English or full text, did not use whole genome sequencing, or it was a reanalysis of publicly available database, or it was not specific to a region or area, or a review article. However, review articles were used to construct the discussion and introduction sections. So in the data extraction, we got the study title, the authors, the year of publication, country, how many cities were sampled, the sources of the sample, whether it was human, animal, environment, hospital, and which pathogen. We also got the period of surveillance, like how long did the surveillance last, and the instruments used, and the bioinformatics tools used. And finally, the aim, conclusions, and limitations reported by the authors of the study were extracted. The first part of the extraction table was basically analyzed using simple descriptive statistics and charts. And an inductive thematic analysis was conducted on the aims, conclusions, and limitations. I'm sorry, I have a bit of a cold. So we started with about 9,000 records, but we ended up with 171 studies included in the review. So in the results, we can see that the use of whole genome sequencing saw a very, very sharp increase in 2020. This was basically fueled by COVID and like how the technique kind of like played a role in the detection of COVID, and this encouraged the widespread application across other conditions. And we can see that out of all the escape pathogens, Klebsiella pneumonia was the most studied. When it comes to the geographical distribution, China was the country with the highest number of studies. And East Asia and the Pacific had the highest number of studies geographically. However, high-income countries still generated the majority of studies. As you can see, they are still the highest, and the studies from upper middle-income countries are basically bolstered by China. China alone had over 30 studies. So there is still a huge disparity. The bioinformatics and the whole genome sequencing techniques used were, we mostly relied on short-read sequencing. It was a lot more common, and a combined approach started to gain traction in 2022. A combined approach is when we use short-read sequencing and long-read sequencing, as each technique has its limitations and its strength, and combining them together would produce the most robust results, but it would increase the time and the financial investment required for the study. The most common tool used was ResFinder. ResFinder is a free, publicly available tool. And 18% of our study sample, the sample of our studies, used it alone, and 27% used it in conjunction with other tools. CARD was the most cited database, and CARD is also publicly available, but it is manually curated, which gives it a strength compared to databases that are automatically created from publicly available data. The thing is, like, a lot of the tools and bioinformatics pipelines are available as either independent packages or Perl and R scripts, and this kind of like allows the widespread usability of these tools, but they do require a level of education and training on the part of the people who use them. Some of the other tools cited were Abricate, Collaborate, Ariba, and AMR Finder Plus. Collaborate is specific to Klebsiella, so because Klebsiella was the most studied pathogen, Collaborate would make sense as one of the most used tools. As for the thematic analysis, this is what we saw in the aims. There is a pathogen-dependent distribution of the aims of the studies, where certain studies had a higher distribution of particular aims. But in general, the aims of the studies that were included were outbreak analysis, where the study was specifically conducted to study the nature of an outbreak that happened in a particular hospital or area. Genomic characterization, where they looked at the pathogen in general in over a longer period of time and not related to a particular outbreak. Some studies kind of like examined the dissemination of AMR across multiple environments. These studies collected samples from humans, as well as like some animals and the environment around them, to study whether they can, whether the environment can be a carrier of antimicrobial resistance genes that can cause possible outbreaks or health issues for humans or problems with farm animals that are used to produce our food. Some studies specifically aimed to test whether phenotypic and genotypic AMR profiles match. And some studies focused on the analysis of a specific strain, where like a new strain was discovered and they wanted to link it to existing strains. Other studies focused on studying a particular gene or a resistance mechanism that was discovered. And some studies were basically testing a specific methodology that whole genome sequencing can be applied. And finally, the last set of studies examined the application of whole genome sequencing as a tool for routine surveillance. So you can see that most of the studies on Klebsiella focused on genomic characterization, while most of the studies on Staphylococcus aureus were outbreak analyses, and this kind of correlates with the nature of the severity of infections with Staph aureus, specifically in hospitals. So as for limitations, there were a lot of limitations identified, mainly with study design and sampling bias. And the sample size, like for a lot of the studies, the samples were generally very small or were unbalanced. So they would, for example, collect like 100 samples from humans or from patients and like 4 or 5 samples from the environment. And this would introduce a sort of bias that would kind of hinder the generalizability of the results. For some studies, the lab data for AMR were missing, or the clinical data of the patients were not reported in the study. There were a lot of limitations relating to sequence quality, and this was also related to the use of short-read sequencing or the overuse of short-read sequencing and not using a hybrid technique. The result, due to that, the difference between short and long read sequencing is that long read sequencing allows the detection of repeats and repeated sequences a lot in the genome, while short read sequencing is generally faster and cheaper, but it does miss some of that depth of data. There were also database and analysis limitations where the database would not be updated or the manual curation would not catch up to the new emerging ARGs or antimicrobial resistance genes. And also there were a lot of time-related and cost-related constraints where they had to get the results fast in order to apply an intervention, or they were limited by the cost of the analysis, so they could run, for example, more short read sequencing analyses, and they could not afford to run more than a limited number of long read analyses. And this also impacted the depth of the data in some of the studies. This is the distribution of how many times each of the limitations were reported. You can see that a lot of the time it was the sampling that was a problem, whether it's the size, method, or sampling bias. As for the thematic analysis of the conclusions, this was basically the most interesting part of the analysis for me, because
you have 2 minutes left.
Yeah, so I'm almost done. So a lot of the studies identified actually resistance reservoirs, whether in animals or in the environment or food or hospitals or actual carrier humans who are traveling across countries. A lot of different strains and lineages were identified, like high-risk strains or new strains or actual genes or mechanisms. Some studies identified the prevalence of specific AMRs, and some identified the actual use of antibiotics and correlated it with the development of AMR and some host-related factors. Some studies evaluated the diagnostic use of AMRs, and some basically focused on recommending the whole genome sequencing for surveillance in the future. These are basically the counts of studies, but I can basically move over these quickly. In conclusion, yes, whole genome sequencing can be used for AMR surveillance, and it is used all over the world, but there is an income-dependent distribution. Despite the resistance itself being concentrated in low-income countries, the use of the technique is very concentrated in high-income countries. Klebsiella pneumonia was the most studied, and routine sequencing is very important to avoid sampling limitations. If we do things routinely and samples are collected on a routine basis, we will avoid the sampling limitations, which are the biggest limitation identified. There are a lot of limitations that are related to the tools and pipelines that can be resolved by applying multiple techniques in tandem. Like if we use multiple databases, one of them will catch what was missing in the other. And finally, there is a large financial investment involved in the application of this technique, in making it routine and in making it standardized. We need to have a standardized process and a clear legislative framework to ensure wider application. In conclusion, it has a future, but it is still long in the making. So I hope that this covered the whole thing, and thank you so much for listening. I am done. Thank you.
Thank you, Niran. Indeed, a very interesting presentation. We're moving on now to questions from the audience. First question is from the select studies. Was any change in trends of the antimicrobial resistance or effective surveillance reported using any of the whole genome sequencing techniques?
Yes, actually, there were a lot of new antimicrobial patterns predicted. A lot of antimicrobial transmission between environments was predicted through the studies. Some of the interesting findings were actually the transmission between farmers and cattle or farm animals of AMR genes. You would have a bacterium or a specific pathogen that carries these genes in the animal that is then transmitted to the human, causing disease that is harder to be treated. And the transmission is actually global in nature because of how the world is right now. People and cargo and items travel all over the world all the time. And the transmission kind of like jumps between countries. Like you would see something detected in China, and then you would see the same thing detected in the United States, for example, a few months after, or in a study that was published about a year later. So it is very important to kind of control for that. Another interesting aspect was that humans can be carriers even when they are healthy. They can be showing no symptoms and they still carry the bacteria that can cause someone else with maybe a worse immune status disease. So it is important to kind of like survey routinely.
Okay, great. Thank you. Another question, did any of the studies provide an explanation or justification why short-read sequencing was the most used technique besides being less costly, and also considering its associated limitations?
Yes. Well, basically, short-read sequencing machines are more easily available. They are easier to operate, and they can analyze multiple samples at once, as well as they kind of like need a shorter time to produce results. In a lot of the cases, they are sufficient on their own to predict something or to show some things, but specific types of resistance patterns or resistance genes do require the addition of a longer read, especially things that rely on tandem repeats. Like short read sequencing cannot show you a repeated sequencing, and this is where the strength of long reads come in. But on the other hand, long reads are more time consuming. They are overall less accurate compared to short reads, and they are, again, require a higher cost to set up to begin with.
Thank you. Another question, what was the standard or control approach used to ensure the quality and precision of this study?
Okay, so this is a scoping review. So the aim of it was to include as many studies as possible. And as per the PRISMA guideline, there is no required quality assessment for studies to be included in a scoping review. My aim for this was to include the highest number possible. However, I did some internal quality check on my own. And basically, I had to like ensure that the samples matched what came out of them and that the results matched the databases. So this was all manual check, and it was took very, very long.
Great. Thank you, Nuran. There are no more questions from the audience.
Thank you.
It was indeed very informative, your presentation. We're moving forward now to have a break from 11:50 to 12:30. And then we will have a plenary presentation from Dr. Chris Owens, a senior lecturer of School of Nursing, Midwife, and Public Health of the Public Health Department of the University of Suffolk. Thank you all. See you at 11:30. Sorry, see you at 12:30, sorry.
So through the Unicaf virtual learning environment, I had unlimited access 24/7 to a well-resourced online library containing hundreds of volumes of up-to-date material. Furthermore, the lecturers, dissertation supervisors are usually very efficient and dedicated to providing timely direction and feedback to assignments. The Unicaf University Accounting and Finance degree programs, delivered by Malawian tutors with good local knowledge and by well-qualified international tutors from around the world, contribute to the development of competent graduates capable of bringing positive change to the corporate world.
Welcome back, everyone.
So we will be continuing with the first plenary presentation for today, which will be delivered by Dr. Christopher Owens. Dr. Christopher Owens is a senior lecturer in public health at the University of Suffolk, where he's part of the School of Nursing, Midwifery, and Public Health, as well as the Institute of Health and Wellbeing. In addition to his teaching role, Dr. Owens serves as a link tutor for the MSc in Public Health program, a program delivered in collaboration with Unicaf. Within a career spanning over 15 years in higher education, Dr. Owens has dedicated his work to public health academia and holds a PhD focused on physical activity and sedentary behavior among adolescents. His research and teaching continue to make significant contributions to public health education and practice. Today, he will introduce us to ripple effects mapping and its applications in public health. Dr. Owens, the floor is yours.
Thanks, Margarita. I'll just share my good morning, good afternoon, everybody. It's morning in the UK. I'll just share my screen with you so you can see my slides. Hoping this works okay. There we go. Is that visible to everyone? If I could just have a nod of heads. Thanks, Margaret. Is that okay? Yeah. Okay. Thank you. So good morning, everyone. I believe I've got 20 minutes for the presentation. I hope you can hear me okay in terms of audibility.
Sure.
And I think we've got 10 minutes for questions and answers roughly at the end of the session. So yeah, welcome everyone to my presentation. It's nice to be able to present to you all today and hope everyone is well. My presentation today is, as you can see on the first slide there, ripple effects mapping. I've come to talk about what ripple effects mapping is and how it can be utilised in public health. So what I'm going to do, as you can see there on the slide, I'm affiliated to the School of Nursing, Midwifery and Public Health at the University of Suffolk and the Institute of Health and Wellbeing as well, where some of the research that I'm going to talk about today was undertaken within that institute. So I just need to acknowledge that at the start of the presentation. I think I'll stick with the way these slides are structured rather than a slideshow, if that's okay. So moving on to the next slide. So the structure of the presentation for this afternoon is firstly, I'm going to give you some context and background to ripple effects mapping, which I've abbreviated there to REM. Secondly, how to undertake ripple effects mapping, adaptations of the method, of the ripple effects mapping method, because there are some slight adaptations, based on the original method. And then I'll move on to talk about reflections on the practicalities of using ripple effects mapping in public health. Both reflections that are positive and also some of the challenges that I've personally experienced in using this research method, and then some conclusions. So I just want to give you a bit of context and background to ripple effects mapping first of all. So historically, if we go back a few years, this method of ripple effects mapping was utilised predominantly within the community development field, an area of research. So that's where it stemmed from, really. And it's, as I've put there on that final point there on the slide, it's starting to gain quite a lot of pace and momentum within public health and public health research. So certainly the research that I've undertaken in public health using this method has been welcomed. So you may have never heard of it before. If not, then I think this will be a really good session to get to grips with what ripple effects mapping is. So basically what we're looking at with ripple effects mapping are the impacts of an intervention or a program predominantly, or maybe a project. But basically you're looking at what are the impacts, particularly the wider impacts that are both unintended, so impacts that were never expected, and also intended impacts as well, those that we did expect within an intervention, maybe from the start of the intervention or program. So it's a mix of unintended and intended impacts, particularly wider impacts. And I've just referenced there an institution called the National Institute for Health and Care Research within England. That's NIHR for shorthand, which is the Applied Research Collaboration in the West of England. And that was from 2022 on their website. I've paraphrased that slightly. So that's the context and background. Now, overall, ripple effects mapping is considered to be a qualitative method as opposed to quantitative. It's a qualitative evaluation method, really. That's what it is. And you'll see why as we go through the slides that follow. It's interactive, that's the main thing, and it's also participatory. So it involves participants working together in collaboration. I think it's a really exciting method, and hopefully that enthusiasm I've got for it is coming across this afternoon in the presentation. So moving on. The background to ripple effects mapping. Originally, researchers, Chasden et al., 2017, they've got a really good field guide that's available. I've referenced it at the end of the slides in this presentation. 2017, that was published, that field guide. And what they proposed is that ripple effects mapping consists of 4 what they call main ingredients main elements. I've called them main parts. So firstly, that involves something called appreciative inquiry. And if you're familiar with qualitative research, that will be a common phrase that you've seen before. So it's appreciative inquiry, asking questions to participants, sometimes focused on quite positive questions. Secondly, it adopts a participatory approach. It's about working together in collaboration to produce the output that I'll talk about in a few minutes. And it's interactive it involves interactive group interviewing and reflection. And finally, it involves something called what we call radiant thinking or mind mapping. It's also termed as, I tend to use the word mind mapping. And those are the 4 main parts. Now, you'll see that reflected within the adapted method that I'll speak about in a few minutes as well, those elements. So next, moving on to some further aspects that were highlighted by Chasden et al. In 2017. I've put the page numbers there of the field guide. There are 5 steps basically that Chasden et al. Proposed, which are firstly identifying the intervention that is the focus of the ripple effects mapping, or what we might call the program. I've just used the words intervention there because that's what the author uses. Secondly, scheduling the event and inviting participants, so scheduling the ripple effects mapping event and getting people involved. Conducting appreciative inquiry interviews, so you can see that coming into play there. Mapping the ripples, and I'll talk about that in a bit more detail as we go through the presentation. And then finally, as you would expect with any piece of research, cleaning, coding, and analysing the mind map, which is the kind of physical output of the piece of research. Now, it is important just to mention briefly, I won't go into any depth here, that Chasden et al. Also have 3 variations in approach that they refer to as well, which there are slight differences between each. So there's something called the web mapping approach, in-depth rippling, and theming in rippling. So those are 3 different approaches. And if you want to know more about those areas, please do have a look at that resource of Chasden et al. 2017. It's really good and it's very detailed. I think it's over 100 pages in that document, but it's good. Okay. Just to pick up on some examples in public health, because that is my area of expertise and interest. So these are just 3 articles I've not chosen specifically, but I think are quite useful to highlight some slight differences in how ripple effects mapping is used. The first paper there in date order is Washburn et al. 2020. As you can see there from the link I've provided to the actual journal article and the reference, they used ripple effects mapping to basically do an evaluation of a community-based health programme. The second paper stated there, is Nobles et al. 2022. Now, this paper is one that used an adapted ripple effects mapping method that I then, in the evaluation I was involved in, we utilised that similar method to that with some slight adaptations on top of that. And that's a really good, interesting paper to read, looking at the wider impacts of system change efforts in public health. Really good piece of research. And then the final paper there, Rodriguez Espinosa et al. 2023, more recently published. As you can see there from the title, They looked at midlife and older adults in a multi-level participatory physical activity intervention, and they used ripple effects mapping there. Quite an interesting paper too. Just 3 examples there of how it's been utilised in public health. So what you do find is from the traditional method of ripple effects mapping, there are some slight adaptations that have been used, which is welcomed, I believe, from reading the literature. And one example is the one I've just referred to, Nobles et al. In 2022. And I won't repeat that word for word there on the slide, but I was involved with leading a small team on a work stream within a recent evaluation where we utilised this method, this ripple effects mapping adaptive method, which closely aligned to the method used by Nobles et al. 2022. And it was also informed by some online training that's really good, that's I believe is publicly available on the NIHR website based in England. Okay, so that's what we did. And we made some additional adaptations to that adaptive method. So what did we do? Basically, we were asked to evaluate what I'm calling an intervention, but it was a program. It was what we call a neighbourhood program relating in the public health field. I'm just keeping it anonymised for now in terms of location, but it was in England. The setting was in England, an area of England. And what we did is we had used an adaptive method where we had what we call an initial ripple effects mapping workshop in person with 2 groups in the same room, but working separately to begin with. And then we followed those as many of those 2 groups up as we could, the people that were in them, the participants, for follow-up workshops around 6 months later after the initial workshop. One of those workshops was in person with the one group, face-to-face, and one was online on Microsoft Teams. That's the beauty of this method. It can actually be, you can actually do it online as well on like this sort of forum. What we basically looked at and what we're interested in are the actions, activities and impacts on a timeline, let's say, for example, over a 12-month period. And what participants did is they put on this timeline that was month by month across the year. So it's never exact, but it's approximate in terms of timeline. The actions that happened, the activities and the impacts that happened as a result of that. So it's what we call the ripple effect. I'll talk about this more shortly. And we had outputs or maps that were produced at the initial workshop, and they were digitized, and impact pathways were identified on each of them afterwards when they were tidied up and cleaned up, and they were subject to initial thematic analysis. And then when we did the follow-up workshops, we did further development of those impact pathways and thematic analysis that was finally done on those outputs. So this is just an image to show you, a diagram, an image of the stages that we followed in the initial ripple effects mapping workshop. This is stage, the first part of the project. So stage 1 is we did appreciative inquiry interviews with participants. There were around 16 participants, I believe, in total, split into 2 groups of 8. But what they did is they did peer-to-peer appreciative inquiry interviews, only for about 10 to 15 minutes, asking each other a series of preset questions that we asked them to ask each other, just as a bit of a warm-up, really, to think about the intervention they've been involved in, the programme, and what some of the successes of it were, and what some of the challenges might be. After that, for about an hour and a half, we basically gave them a huge sheet of paper on a table, and they put a timeline across the middle over, I believe, to a 12 to 18-month period this was, so it's sort of going back retrospectively and thinking what's happened. And what they did is they mapped the impacts of what happened. So what happened, what was the impact, and what are some of the activities and actions that contributed to that impact or those impacts. Quite challenging to think about this, and sometimes the participants had to work backwards from the impact to think, okay, what contributed to this, what influenced this impact? And you'll see that on one of the images I'll show you shortly. After that, they reflected on the impacts as part of that 90-minute stage, and we used a series of questions to get them to think about, and we used a colour code to match up those questions and the answers. Stage 4, we reflected on the most and least significant changes or impacts of participants. So that was quite challenging, and that was literally a case of putting a written symbol on the piece of paper on the mind map to show a plus sign for what was a significant change, a minus sign for the least significant change or impact. Again, it's quite subjective, this, but it's very much based on judgment. And then stage 5 was the group feedback and learning stage. So 5 stages that they worked through in the initial workshop. As you can see here, this is quite a nice image. This shows you what was produced in that initial workshop on the day in the room. Now, this is split into 2 because I couldn't fit it on one screen. So the top image is the start of the ripple effects mapping output that was produced on the day. And as you can see, there's that timeline going across the middle. And you've got all of these impacts in activities and actions coming out that are linked by an arrow. And then the bottom image is basically the extension of this output because I couldn't fit it on one page. So that's what it looks like. It looks a bit messy, but then you have to convert it into a file to tidy it up. So after that, the follow-up workshops occurred. We included as many people as we could in these follow-up workshops. We followed the same steps as the initial ripple effects mapping workshop that I just went through, but we simplified them more. They didn't take as long usually. And we utilised not that image I've just shown you, this one. We actually used a tidied up image that was digitised and printed that out again and brought it along to the session. Or if it was on Teams, we showed it on the screen and we inputted onto the image for the participants. The key thing to say is, in the initial workshop, we said to the participants, what do you predict is going to happen in the next 6 months from the date of this initial workshop? And they plotted on the image, on the output by hand, what they predicted some of the impacts would be in the next 6 months. And then that was what was reflected on in the follow-up workshop. Did those things happen? If they did, that's good. If they didn't, why didn't they? Are there any impacts that have not been included? So that's what you look at within the follow-up workshop. It's very much based on time-based events. I think that's fully covered there. There's an example of what we did in the follow-up workshop. So that's what was, you can see there, that was this is just the end of the output from the initial workshop, the ripple effects mapping workshop. But this shows you what's been added at the follow-up workshop. So those were some of the things they predicted that are typed. And that was the work that was undertaken in the session that got added to basically by hand. And then we had to transfer all that onto a clean digitized version after the event. The one that was done via Teams, the follow-up workshop that was done by Teams, we were able to do that on the screen in the session with the participants. But obviously in person, it looks like that. So I hope that helps for you to see. Yeah, that's what we did after the follow-up workshop. We digitized outputs in relevant software. So there's lots of mind mapping software that can be used, it's quite flexible. And we built on the impact pathways. New impact pathways are identified as well. And we did further thematic analysis to come up with themes. And the main thing to remember is that the impact pathways tell a story of what's happened in the intervention. There's a link to the outputs, including the final outputs and impact pathways. We have an evaluation report there on SWAY. But what I've done is I've created, I don't know if we've got time to show you both of these, but this is an example of what the output looks like when it's been digitized. So I'm just going to click play. I might not show you all of it, but I just want you to see what it looks like when the output that was quite messy earlier is digitized at the very end. After the final workshop, when you bring both all elements together. And as you can see there, as the screen moves across, it looks a lot nicer, it's more fluent. So that's what it looks like. Okay, and the colours, the reason for the different colours is because we asked those questions in the reflection stage, and that's what are represented there. Okay, and if I just scroll to the end of this image, these are the dates towards the end that were predicted, and that's the tidied up final output. If I just move to the next slide quickly, this shows you what the impact pathways look like on that exact same output. So you can see there are boxes in different colors around there. Each color represents a different impact pathway. So you can see we've got green, blue, yellow, and that represents the chain of events that have happened for an impact. So I'll just scroll along a little bit more because I know we're getting a little bit short on time, but you can see there, it goes right across. This takes quite a lot of time to analyse and output. So it's very, as you can see, very qualitative. So just to move on, those are examples of impact pathways there. There were 14 impact pathways on that image I just showed you quickly. This is an example of one impact pathway. So you can see that from left to right, you've got the actions, the activities that have happened, and at the very end, you've actually got the impact that occurred as well. Okay, so that's an example of an impact pathway. So, couple of minutes left. I'm just going to reflect on the practicalities of using ripple effects mapping. My overall summary is it's really useful to use when you're evaluating interventions and programs in public health, particularly where it's complex. You've got the complexities of interventions. I think that last point I've put there, you need to be clear on what is being evaluated. So it's really important that you look at, so if you're looking at an intervention, it's very important to break it down to the different types of programs within an intervention, for example, and doing separate output for each, because it can get quite messy and complicated if you're trying to do one massive intervention with lots of elements in it. But if it's one intervention on its own, it's quite simple to do a straightforward output and map. I hope that makes sense, but the literature's very clear on that. It's interactive, participatory, it's really good. People work together, you've got and what I should say is that stakeholders are the ones that are invited to these ripple effects mapping workshops. So stakeholders can be those that are directly affected by a program or intervention, or indirectly. So that can include those that are running the program, the intervention, participants, a range of stakeholders. It's good to have a range of stakeholders in the room. Participants enjoyed it in my experience of this project, and it's really good for motivation because participants can see what's been achieved, what could be better. It does capture it very well. And just to say, this is quite an ongoing process of ripple effects mapping. There are new methods that are being proposed, adaptations to the method all the time. But it can be really challenging, so it's really important to be very organised with it. Conclusions. I think it's an effective method where you want to qualitatively capture the impacts of an intervention. There are some limitations in that it's not so quantitative. It's important to be aware of challenges in using ripple effects mapping, and key thing is to be pragmatic with it. Sometimes you have to think when you're actually doing the session how you could make it improve the session as well, actually on your feet, so to speak. So being pragmatic is key in my experience. But it's a very useful method in evaluation, and I must say, in addition to other methods being used as well, other data collection methods. So just to conclude, there are some references there for all the ones that I've cited, all in alphabetical order, and thanks for listening. Thank you very much.
Thank you very much, Dr. Owens, for this insightful and constructive presentation. My first question would be, in what ways can the ripple effects mapping be adapted to suit different public health contexts? And what are the practical challenges of applying these methods in diverse settings?
Okay, thanks, Margarita. Thank you very much. So yeah, this method, this ripple effects mapping method, it's a bit of a mouthful, that can be applied to many contexts in public health settings. If I take the example that we used, that was a neighbourhood community programme that brought together not necessarily the recipients of the programme, the intervention, but those that were responsible for delivering it, the staff that were involved in delivering it. So that brought them together, and the funders of the programme. So it can be applied in that kind of context. I've seen it applied in contexts where in other parts of England, in another county, a big area where they looked at physical activity intervention, and so a different setting completely, but they wanted to understand the experience of those that had implemented the programme as well, so that they were involved in the ripple effects mapping sessions. So it can be applied there. Of course, it's very flexible in other areas of public health as well. I think it just has to be appreciated that it is a qualitative research method effectively. And what was the second part of your question? Sorry, Margarita.
And what are the practical challenges of applying this method in diverse settings or different health contexts?
Some of the practical challenges really of this method are, okay, you invite, it's like any piece of research, you invite participants to take part, they complete consent forms, you've gone through the ethics approval procedure as well, which we did with this project, really important, is actually ending up with the participant number that you need as well is quite a challenge. So I would say natural participant attrition, in terms of retention of participants, particularly when you're doing it longitudinally like we did. So you have the initial workshop, then the follow-up. That's a real challenge to keep as many of the same people in the follow-up workshop, because you want the same people involved because they've contributed to the original map. So you want them in the follow-up session. That's a real challenge, is to try and keep as many people there for the follow-up. Naturally, maybe participants can't make the date, or other reasons. Things happen in employment as well, don't they, with interventions that are funded. So that's a challenge. That's a real challenge, is participant maintenance, if you like. That's what I would say.
Okay, lovely. Thank you. Another question. Would it be possible to give us a bit more information or details on the physical activity intervention you mentioned? Was it part to get an insight of understanding the reasons for physical inactivity, or to evaluate the intervention?
Good question. The paper that I was that's the paper I was referring to there with the physical activity. I think it's called We Can Move. It's published it's in the public domain. It was by Nobles et al. In 2022. And really, my judgment is it's a strong paper, strong journal article. And yes, that was more looking at the intervention itself in terms of the changes that had happened, the wider impacts, system changes. So it's quite broad. It's really, really interesting to read that paper. I've referenced it in my reference list. And the article, you can see in detail the method they followed. You can see some of the outputs as well. Really interesting. And they actually numbered their impact pathways rather than just color-coded them like we did. They actually numbered them. So it's a lot more, it's probably clearer to see actually on their image if I'm making a judgment of comparison there. But yeah, that was looking at more the intervention rather than physical activity changes, so to speak, amongst participants.
Thank you very much. And a final question coming from the audience. Are there any technological tools that can support the execution of this process?
Yes. So some of the software tools that can be utilised are those for the mind mapping software. There are lots of mind mapping software packages that can be used. I believe one of them is called Lucid, Lucid, which is the one that I believe, well, we adopted the use of that one to produce those nice clean outputs that I just showed on the screen. That was quite effective. That's one that comes to mind. I believe the paper that I was just referring to by Nobles et al. In 2022, they do state the mind mapping software they used as well. I can't remember the exact name of it, apologies. But yes, there's lots of mind mapping software packages that can be utilised. That's the main thing you need really with this whole process. Of course, with the qualitative analysis, the thematic analysis that we did, we utilised NVivo to do the qualitative analysis. That was the software package that we used. I don't know the version, but it would have been the most recent version that we utilised in terms of tree nodes and nodes to work out the themes from. And when we did the thematic analysis, the impact pathways are really important. They form part of that. They tell a story. But you're actually doing the thematic analysis of the output on its own. And it can be going back to one of the other questions about practical challenges. What we had to do is we analysed each output separately. We did separate thematic analysis on each output that we produced. We had 2 outputs. And so we ended up with separate themes. And then we tried to, because they were part of the same programme, we tried to look at any overlap as well in terms of common themes between both outputs. And that was quite helpful as well. But there's always different ways of doing it.
Thank you very, very much. Thank you for your time. your insightful presentation, and we really appreciate you being willing to present to our conference today. And also grateful for all the excellent collaboration we do have.
Thank you very much. Thank you very much. Appreciate it. Thanks for inviting me. Thank you.
Bye-bye.
Bye-bye. Thank you.
So we will proceed with the second session of today's conference day. The next session will be session 7, Energy Management and Sustainability. This session will be chaired by Dr. Reginald Dennis Guisey, Pro-Vice Chancellor Academic Unicaf from the Unicaf team. Dr. Reginald, are you here? He was here. I don't know if he experiences any connection issues. Okay. I will start with the first presentation until Dr. Reginald joins the meeting. I don't know if he experiences at the moment some connection issues because he was in a few minutes ago.
And we're trying to reach him, but okay. But I think we can proceed. We have the two first presenters.
With us. Yeah. Okay, the first presentation will be by Simon Ojoyo Aranciola. He will present a review on the analysis of carbon dioxide emissions per sector in Nigeria, effect on climate change and the mitigation measures. Simon, can you hear us?
Yes, I can hear you.
Perfect.
Hear me?
Yeah, we can hear you very well. You will have 15 minutes for your presentation, followed by a 5 minutes Q&A session. And I will let you know when 2 minutes will be remaining for the end of your presentation, so as to know when to wrap up.
That's good.
It would be very nice also if you could turn on your camera so we would see you while you're presenting.
Okay.
Thank you. Perfect. Okay. Can you share your presentation with us?
Okay.
Whenever you are ready, the floor is yours.
Okay.
Can you also enhance the light in the room, because we can see you very dark, almost like a shadow, let's say.
Okay.
Much better. Thank you.
Yes, is my slide on?
Yes, you can do it as for slideshow so we can see it.
Okay. Are you okay now?
Yeah, you may start. Yeah.
Okay. Yeah. Good day, all. It's nice to be here. My name is Aranciola Simon. I will be presenting my research thesis topic, analysis of carbon dioxide emission per sector in Nigeria, effect on climate change and the mitigation measure. To start with introduction, this study look at major sector of the Nigerian economy that contribute to anthropogenic CO2 emission by investigating the cause and effect relationship between these emissions and the climate change. As we all know that CO2 is a major greenhouse gases that causes climate change. And one of the front burner issue globally is the issue of climate change. And we ought to know that this climate change, we are responsible for it due to our industrial activities. So it is good time that we begin to look at how to tackle this climate change by looking at those activities that we are responsible for, how to control them, and how to mitigate them. So previous studies have shown a strong link between CO2 emission and economic growth and industrialization, according to Azam et al. 2016. And this,
sorry to interrupt you. We cannot see the next slides if you are moving your slides from one to another. Can you put it into slideshow so you can we can actually see your presentation?
okay.
At the bottom right corner. Bottom. Do you know how to slideshow your presentation, or should we do it for you?
Okay, let me. Okay, you can do it for me because I'm having an issue here.
Okay. Can you please stop sharing your screen so we can share your presentation?
Okay, okay.
Unicaf colleagues, can we please share onto the screen the presentation of Simon?
Are you okay?
Simon, you have to stop sharing so we can do it for you.
Okay, okay.
Perfect. Unicaf colleagues, can you please retry? Perfect. Okay, Simon, you may resume.
Okay, I think I'm okay. So previous study have shown strong link between CO2 emission and economic growth and industrialization. And Nigeria as a country, we are in the phase of economic growth and industrialization. That means Nigeria now generates more CO2 emission. And it's time for us to look at this issue of climate change caused by CO2 emission. Also, notable environmental changes in Nigeria has also been brought forward as a case study. So we have notable climate change like drought, flood, erratic rainfall pattern, and deforestation. So this study used secondary data from the emission database for global atmospheric research and climatewatch.org to investigate the distribution of and evolution of CO2 emission across selected industry from the year 20,000 to 2022. The next slide. So in this slide, we can see the kind of chart that shows each of the sector. We have the transport sector, the processes, the power industry, industrial combustion, fuel exploration, building, and agriculture. And the other slide shows how the progression of the emission in the last 2 decades. can see agriculture has been growing, though in a very slow pace, building. The one that caught our attention is that of transportation. You can see that transportation sector has grown in a very fast rate. So this is necessary for Nigeria as a country to study how each of this sector has contributed to the overall emission, so that this can help us in policy making and also in resources sharing in order to take care of this emission. The next slide. The next slide. Problem statement / purpose of statement. Nigeria lack comprehensive data on specific CO2 emission resulting from human activities in each of the sector of the economy. This lack of information often leads to misallocation of resources that are meant to reduce CO2 emission. As we know, Nigeria is a member party to the Paris Agreement, who have the sole responsibility of reducing emission. But back at home, we discovered that there are no comprehensive data on each of the sector, how emissions are being generated, how they contribute to the overall emission. So this research will help us to look at the data background behind the sectors that have been mentioned, how each of these sectors contribute to CO2 emission. As I mentioned earlier, the sectors are agricultural sector, transportation, manufacturing, processes, and transportation. So therefore, this study aimed to rectify misunderstanding regarding CO2 emissions in Nigeria by examining individual sector contribution to the overall CO2 emission, so that we can implement a customized strategies in every sectors, so that at the end of the day, Nigeria as a nation can be able to achieve its emission reduction strategies and commitment to the Paris Agreement. The next slide. So aim and objectives of this research. This research aimed to conduct analysis of carbon dioxide CO2 emission across various sectors in Nigeria and examine their impact on climate change, and additionally try to identify potential solutions to mitigate the effects of emissions. Next slide. Research questions. That the following research questions crop up in the course of undertaking this research. Number one, how is each sector of Nigerian economy contributing to the increase in CO2 emission? And what is the extent of each sector contribution to the overall CO2 emission in Nigeria? Secondly, are there empirical evidence linking CO2 emission to climate change? Because in Nigeria today, we are beginning to have record of climatic change conditions like droughts, erratic rainfall in Nigeria. So it's a time we ourselves questions that how did we get there? What are the causes of these things? And these are the reality of CO2 emissions that come from our processes and industrialization. And also thirdly, how have any mitigation measure been implemented to address CO2 in the past? So if that is the case, how effective are these mitigation factors? And how can we continue from here when we now have a database that gives us a clearer picture of this sector contributing to the overall emission? Next slide. So methodologies. This research employs scientific approach, particularly quantitative analytical techniques. According to this approach, data were collected, and I try as much as possible to stay unbiased and impartial, looking at the database, the empirical data critically. And we focus on the selected sector of the economy from the year 2000 to 2020 to delineate the research boundaries. Statistical methods such as mean mode, variance, correlation were used to establish strong connection between CO2 emission, a major greenhouse gas, and the climate change. Next slide. Methodologies, data source, data were collected from worldbank.org, climate change knowledge portal, emission database for global atmospheric research, and World Resource Institute. Next slide. Research questions. So we try to answer some of the research questions that we have raised before. How is each sector of Nigerian economy contribute to the increase in CO2 emission? What is the extent of each sector contribution to overall CO2 emission in Nigeria? This was investigated based on secondary data available on EDGA for each of the sector in view from 20,000 to 2020. The second research question was to examine the correlation between the total emission and the occurrence of climate change, because we need to make sure that we establish a relationship between emission and the effect of the climate change. Doing this research in isolation will not bring out the appeal that is needed. So we have to make sure that we look at it, emission and the effect of climate change. We have to bring them together, synchronize them together, so that it can be given the right and attention. Yeah, the next slide. The finding indicates a shift in emphasis. Looking at those sectors, we discovered that there is a shift in emphasis. Before now, you have this mentality or notion that emission majorly come from exploration sector. But based on this data, we discovered that there are other sectors that must be given proper attention. For instance, the transport section. From the data that I shared before, we discovered that the transportation section contributes about 47% of the total emission. So compared to fuel exploration, which accounted for 19%. The reason being that in Nigeria, most of oil and gas activities in Nigeria are now basically reduced to only drilling. Nigeria now export more of crude oil outside the country. So that brings down the quota from fuel exploration. And why we have more of emission from transportation is that in Nigeria, we have a lot of second-hand cars, low efficient cars. And some of our cars still run on hydrocarbon fuel, which have a lot of carbon footprints. So by examining the causative association between CO2 emission and flood occurrences in 20 countries, I try to look at, from other data sources, countries that were most affected by flood, and Nigeria happened to be 10th among those countries. So this brings us to the fact that indeed we have the effect of emission in Nigeria already, if we can be around 10th among other nations that are mostly affected by flood. Next slide. So you can see from this chart, these are countries most affected by flood. Source, World Resource Institute. You can see top in the list is India, with about 4.8 billion affected by flood. Then if you look at the other side, that is CO2 emission in tons from India. India now contributes approximately 2.7 trillion tonnage of CO2. So we can see all these countries affected by flood also have high record of emission. So this shows that there is a correlation between CO2 emission and effect of climate change, of which flood is one of them. Next slide. So in conclusion, so analysis of carbon dioxide emission by sector offer a thorough comprehension of the performance of each sector and the level of intervention and regulation needed to address carbon dioxide emission and the resulting effect of climate change. So it is important that we look at it sector by sector so that we can know where to put more concentration and more effort. The result also helps us to be able to make use of our resources, limited resources, because we don't have all the resources to tackle this emission. So if we break it down, it will help us to be able to make use of our limited resources in order to address CO2 emission. The finding indicate a shift in emphasis, just as we have already seen. The transportation industry now contributed to 47% of carbon dioxide emission in Nigeria, as compared to fuel exploration, which accounted for 19%. So solutions lies in the initiative aimed at reducing CO2 emission in the transport sector. And for us to be able to do that in the transport sector, we must be able to look at the alternative that we have to run our cars on low carbon fuel, which will also help us to reduce emission, and to also invest in fuel efficient car, to invest in the new development technology in the transportation section that can help us to reduce this emission drastically. The study revealed a significant Pearson correlation coefficient of 0.49 between carbon dioxide emission and the population impacted by flood. So this finding reinforced the notion that human activities are the main contributor to carbon dioxide emission. We are responsible for the emission. We are responsible for the emission. So additionally, by examining the causative association between CO2 emission and the flood occurrences in the 20 countries most affected by flood, the study revealed a substantial correlation between CO2 emission and the climate change using the Pearson correlation techniques. The next slide. So these are some of the mitigation measures that I try to summarize here. So to tackle the development challenge presented by climate change, it is imperative to implement all-encompassing adaptation and mitigation measures with the goal of diminishing vulnerability to future climate change. We have to start taking steps now in order to address emission. We must set policies in place right now so that the future generation can follow the blueprints. Also, we must decouple our economy from fossil fuel, because presently Nigeria economy is largely dependent on fossil fuel. Then we must be able to look at the alternatives that we have so that we can be able to address the issue of climate change. And what are these alternatives? Our power sectors must deviate from the use of fossil fuel to the green alternative and the renewable alternative. We must be able to make sure that we make use of fuel with low carbon footprints. We must be able to make use of fuel, green fuel, to run our economy. So renewable energy resources must be maximized to the full potential. And fortunately, Nigeria is blessed with renewable energy resources. We have sunlight, we have hydro dams, which can be used to support our economy in order to reduce emission and decouple our economy from hydrocarbon. So the transport section must either be electrified or adapt to low carbon or carbon neutral fuel. And each sector must collaborate in sharing resources. We have to share resources so that all the sector in the same way can reduce emission at different levels. this requires a lot of collaboration and sharing of technology and idea across the sector, so that the overall goal of reducing emission of CO2 emission in Nigeria can be achieved, and also we can reduce the effect of climate change that is presently ravaging the country. Next slide. These are some of the references that I made use of in the course of this thesis. Yeah, thank you for having me.
Thank you very much, Simon, for your presentation. I will give the floor to Dr. Reginald Dennis Guisay, who can proceed with asking some questions. He's the Pro-Vice Chancellor Academic at Unicaf and an excellent colleague of mine. Dr. Reginald, the floor is yours. Can you hear us? We cannot hear you.
Hello,
Hello,
hello, hello.
can you hear us?
Yes, I can hear you. Confirm you can hear me now.
Yep.
Hello, can you hear me?
Yes.
Can you hear me?
Yes.
Oh, wonderful. Yes, good afternoon, colleagues. My apologies for the network and power challenges. I'm very delighted to have joined a
We are facing some connection issues, it seems. Let us wait for another minute or so to see if Dr. Reginald will restore his connection. Otherwise, I will proceed with asking you a question, Simon, regarding your presentation, okay? Okay, I will proceed with asking you one question due to time constraints, and we will proceed. What are the key sectors contributing to carbon dioxide emissions in Nigeria?
Okay, I've mentioned them. We have the transportation section. We have fuel exploration. We have processes. We have industrial combustion. We have power.
Deforestation, correct?
Agriculture.
Okay. What interventions are suggested to mitigate the impact on climate change and associated phenomena like flooding, for example?
What are the?
What interventions are suggested to mitigate their impact, to limit their impact?
Yeah, to limit their impact, because we all know that CO2 emission is a major contributor to climate change. So for us to be able to address the issue of climate change, we must come down to the level of our activities that generate this CO2 emission, which are broken down to those various sectors like transport, processes, industrial combustion. Now we need to now address this issue. How do we release CO2 to the atmosphere from each of this sector? Take for instance, transportation sector. What do we do to reduce emission in the transportation sector? Because what we observe is that right now, most of our cars in Nigeria are second-hand cars. Most of them run on hydrocarbon fuel. So to be able to address emission from that sector, we now look at it. What are the alternatives? What are the options that we have? And these options are, number one, let's make sure that we have policies or regulation in place to reduce importation of second-hand cars into the country, which will deter people from buying second-hand cars, which release a lot of, these cars are not fuel efficient and they release a lot of CO2 emission. Also, we also have alternatives in the transport sector. Can we adapt our vehicles to run on low carbon fuel? Or can we adapt our cars to run on electric vehicles if that alternative is readily available? Or can we make sure that we also look at the option of gas? Instead of our engine running on diesel and fossil fuel, we can also come down to gas, which has low carbon footprints. Or we can also look at how to develop engines that run on hydrogen as a fuel, which is carbon neutral. So those are the options. Then also coming to our industries, how do we make sure that we electrify our processes at the industrial levels? What I mean by that, in Nigeria today, due to epileptic power supply, every industry seems to have a captive power plant that run on hydrocarbon. So if we can optimize our grid system, that we electrify everywhere, those companies do not need to have a captive power plant. They can connect to the grid. And we also have the option of renewable energy resources like hydro, which is zero carbon neutral. We can make use of this, investing in that sector to power our grid system so that industry can be electrified. Also, our industry can also make use of carbon capture storage to recover even the CO2 that is meant to be released to the atmosphere. This can be captured and converted back to biodegradable substance. So this emission can be reduced. Once we reduce this emission, definitely the release of CO2 concentration in the atmosphere will be reduced, and the effect on the climate change will also be reduced. Thank you.
Thank you, Simon. Dr. Reginald, can you hear us now? Are you back with us?
Yes, I can hear you. Confirm you can hear me.
Perfect. Yes.
Wonderful.
We may proceed with the second presentation, and I will let you take the lead.
All right. Thank you. Maybe before the last question for Simon, I would like to understand a little bit more, because he is talking about a pertinent discussion. Once we talk of sectoral analysis of climate change, we begin to think of nationally determined contributions. Now, in your country, what are the indices that we are supposed to look at in order for us to efficiently come up with the percentages of 47%, which you have highlighted, versus the 19%, which you have also highlighted on fuel? Considering that you're also studying the period between 2000 and 2024, it will also be good for us to have a good understanding of the trends over time. I know Nigeria is popular with the concept of importer-exporter. There's also the concept of oil and gas processing plants and so on. And recently, Dangote also started doing a refinery. So can you just break it down a little bit for us so that we understand the ripple effects that may exist coming from the source up to usage, particularly in the context of circularity? Thank you.
Yeah, thank you. Yeah, as I said earlier, if you have joined us in the course of the presentation, I've already shared a slide. So this, the data source, for instance, the data source that I use was from global research atmospheric, which are known to be a body that conducts this CO2 emission data globally. Because in Nigeria today, we don't have provision for carbon reporting and carbon audit. So we have to rely on the external source from the Global Atmospheric Research Institute. And they are the one, from their data, we're able to see those sectors and their contribution to the overall CO2 emission. So they put transportation section as the one that contributed the highest. And it follows that way. So that was how I was able to come up with those data from secondary data from Global Atmospheric Research Institute that I made. This is just to show us the empirical data, how each of this sector contribute to the overall CO2 emission. Now, coming down to the Nigerian factor, we now need to look at how, because obviously those data can be related to the actual facts and occurrences in Nigeria, because just as you said, we have a lot of industrial activities going on in Nigeria, a lot of cement industries, and I told earlier that we have Nigeria with over close to 200 million populations. We have a lot of mass vehicle traffic in Nigeria, and some of these vehicles are making use of low efficient, fuel efficient cars. Some of them are second-hand cars. So these are the things that contribute to the CO2 emission generally. And also the government have been taking initiative, because Nigeria is part of the Paris Agreement. They have been taking initiative to address this emission. But this initiative, if it's not backed up by empirical data, will not be able to make use of our limited resources at hand to be able to address each of these sector, how to be able to look at each of the sector and reduce the emission based on each of the sector, because our resources are limited. Our resources are limited, so we can be able to reduce. And also knowing the fact that Nigeria is a hydrocarbon economy, so we have to progress gradually. We start from low carbon footprint until we get to zero carbon footprint. So the initiative is that looking at those data, we can make policies. We can make policies that we can use to address CO2 emission.
Thank you very much, Simon Aranciola. Thank you for such an interesting presentation. I think we'll proceed now to the next presenter. The next presenter is Revatu Mapala. Revatu Mapala. Please, can you, Simon, can you drop down your presentation? And then Revatu Mapala, can you please upload your presentation so that we are able to share it, so that we are able to see it, in order for us to move to the next presenter. Revatu Mapala is going to present on assessing the impact of the UAE's sustainable and modern energy strategies on oil business viability. Revatu, you have 15 minutes to present. Thereafter, we'll share some questions from the audience. Then we'll also expect some reactions and responses from you as you build up. Thank you. Please, may you proceed. Make sure your presentation is on slideshow, please.
Thank you. Can you hear me?
Yes, we can hear you, Revatu.
Thank you. Greetings, everybody. My name is Rebatu Mapala. I'll be presenting my abstract with the topic Assessing the Impact of the UAE Sustainable and Modern Energy Strategies on Oil Business Viability. I'll proceed to okay, there we go. I'll proceed with the introduction. With the energy industry accounting for 60% of global greenhouse emissions, according to the United Nations, we have scholars like Lee and his friends linking successful global economy decarbonization to fossil fuel business model transformation. As oil-based economies align with the 2015 Paris Agreement and pursue their declared emission reduction targets, it is imaginable that oil companies will face new regulatory environments and microeconomic conditions. Reforming GCC economies away from oil dependency through fiscal reforms has been an urgent priority, according to Terim and his friends. And then we have another author, Seminuk and his friends also. They have cautioned that the industrial change rate required to achieve a low carbon economies around the globe could collapse the fossil fuel industry. My problem statement is very short. The implementation of energy transition related strategies in oil intensive economies like the UAE has contributed to perceived oil businesses' weakened resilience. And the purpose statement, which takes over from the problem statement, crude oil is a financial asset with trading financial derivatives far exceeding physical production and consumption. So besides production and consumption, oil is also a trading asset. So looking into the future is very important. While Samor, Baskaya, and Tesor recommend devoted studies on long-term linkages between the economy and renewable energy, Vasil Jeva and his friends propose research into compatibility of OPEC countries' energy transition objectives with oil market prospects. The study explored the feasibility of the oil business amid climate-centered energy policy reforms to help oil business role players understand the looming microeconomic and legislative risks. What was the aim of the study? The study aimed to explore the impact of UAE sustainable energy policies on the traditional oil business outlook, following the endorsement of the United Nations 2030 Agenda for Sustainable Development. To fulfill the research aim, the study implemented measures to, number one, analyze the UAE's oil business growth by comparing oil production rates pre and post 2015. To compare the role of oil and renewable energy resources in the UAE's electricity production over the years. To analyze the evolution of oil product demand in the UAE energy market. Assess the UAE's domestic oil business profitability pre and post 2015. Analyze the evolution of oil significance in the UAE's economy. Then moving on to the research questions. To assess how the UAE's sustainable energy policies affected the oil business outlook, these sub-questions were addressed. How did the UAE's plans to increase renewable energy alternatives affect the oil share in the UAE's energy mix? How did the UAE energy sector diversification affect oil and oil-related product consumption? How did oil production profitability evolve over the years in the UAE? How did the significance of oil contribution to the UAE's economy evolve over the years? And then we are moving on to the methodology. An exploratory approach was applied to dissect the suspicion that increasing sustainable and modern energy in the UAE's energy mix affected the traditional oil business outlook. The study conducted a longitudinal analysis of secondary oil industry performance data and identified trends in the behavior of select measurable oil business aspects over the years, affirming or debunking the perception that modern energy policies impacted traditional oil business viability. We move on to the results. First, we look at oil production. Data from the Federal Reserve Bank of St. Louis 2023 indicated that the UAE's oil production rate increased from an average of 2.1 million barrels per day between 2000 and 2014 to 2.9 million barrels per day between 2015 and 2024. I think we can see that there's growth there. The IEA Data Services 2023 shows similar oil production patterns, with the UAE's oil production rising from a daily average of 271,000 terajoules between 2000 and 2015 to an average of 998 terajoules per day between 2015 and 2021. However, the UAE's downstream performance, shown by the IEA Data Services 2023, indicated stagnant oil refinery into products like gasoline, diesel fuel, asphalt base, fuel oils, heating oil, kerosene, liquefied petroleum gas, and petroleum naphtha, remaining around 2 million terajoules per year from 2016 to 2021. Still on production. Okay, we are looking at the role of oil in electricity production. World Bank data shows that between 1972 and 2012, 100% of the UAE's electricity was generated from fossil fuels. In 2013, oil source-related electricity generation dropped from 99.91% in 2014. Sorry, it dropped to 99.91% in 2014. And then it fell further to 99.74. And then in 2015, it was at 99.77. Inversely, at the same time, electricity production from renewable energy sources increased starting from 2013. According to the IEA 2023 data, the UAE's oil-based electricity generation has failed to regain momentum since 2017, while electricity production from renewables as a percentage of total increased from 0.3% in 2014 to 4.2% in 2021. We move over to the renewable energies and total energy supplies in the UAE. The broader picture of the UAE's total energy supply, as depicted by the IEA data, shows that oil sources still hold the second largest share of the UAE's energy mix, even after 2015. So oil is still prominent in the UAE, according to that data. IAE Data Services 2023 shows that from 2009, when renewable sources like solar and wind were introduced into the UAE's total energy supply, momentum increased sharply from only 1,723 terajoules in 2018, all the way to 24,481 terajoules in 2021. So from the above, we can see that the inroads made by green energy sources into the UAE's energy sector in barely 2 decades indicate the threat posed by aggressive energy sector reforms to oil dominance in the country's total energy supply. When we look at oil products consumption trends, the IAE Data Services shows fuel oil and jet kerosene consumption has not changed since 2000, and that diesel consumption dropped from an average of 150,000 terajoules per year before 2014 to less than 100,000 terajoules per year from 2015 to 2021. However, motor gasoline consumption rose significantly from 81,768 terajoules in 2000 to 333,435 terajoules in 2021. And LPG uptake rose from over 37,000 terajoules in 2000 to 219 and above terajoules, sorry, that was supposed to be terajoules in 2021, indicative of growing demand. And oil profitability. When we look at oil profitability, we can see that with growing difficulties in oil production due to the rise in resource scarcity and regulatory requirements, these were met with deteriorating oil prices. From nearly $112 per barrel in 2012, annual average global oil prices fell to $66.20 a barrel between 2015 and 2024. The break-even external or the minimum per barrel oil price required for the UAE economy to cover production costs declined from around $75 per barrel in 2009 to an average of $29.51 between 2015 and 2024. With the average price per barrel of $66.20 in the same period, the UAE economy generated substantial profits from oil production. Now we check the oil contribution to the UAE's GDP. The UAE's oil real GDP has not been consistent over the past 24 years. We have seen negative oil real GDP percentage growth being observed between 2007 and 2009 during the global monetary crisis. Another real GDP, the oil real GDP percentage decline followed the 2014 oil price crash. And then we had a 3-year consecutive oil real GDP decline, which was observed over the global COVID-19 pandemic when global industrial activities subsided. We move over to the conclusion. The study reveals that the UAE's oil sector continues to expand amidst renewable energy expansion strategies attributable to economic gains from dropping break-even external oil prices. The introduction of renewable energy sources continues to undermine the significance of oil sources in critical economic activities like electricity generation. However, the popularity of critical products like motor gasoline and liquefied petroleum gas kept rising, confirming crucial gaps not yet filled by modern energy sources within the UAE's energy sector. This affirms Shehi and his friends' reservations about the practicality of renewable energy meeting energy demands. Although low break-even external oil prices benefited the UAE's economy, the benefits could not be extrapolated to company-specific operations, and the study could not confirm with certainty the profitability of oil production or lack thereof at the oil companies level. Thus, future studies could focus on understanding how the UAE's diversified energy mix affects specified oil companies. And then the next slide would be basically the references as seen over there.
Thank you, Rebatu. Gyalebo Hama, thank you for the opportunity to present to us. And you really did it on record time. You still had 2 or more minutes. Now, shall I open the floor for some questions? I think the first reaction we have here is saying it's actually a comment. They are saying, I think the presentation is okay. However, it has been presented as a long report and it is not sufficient enough as a presentation way or presentation mode. Thank you very much for that from one of our contributors. I think it's for us to improve, particular in the context of maybe adding some synthesized data in terms of figures and tables. I'll also add a question for you, ma'am. Quite interesting that you are reflecting on energy mixes and the implication of renewable energy for UAE. Could there be a potential of a focus by the UAE economy to continuously export oil and increase its renewable energy use within the local economy? Is that potential there? And would you want to share how it has transcended over time? Are we seeing an increase of renewable energy use versus fossil fuel use? Thank you.
Thank you for the question. I would think most of the production growth that we are seeing in the UAE's oil industry is for export, because definitely the domestic consumption, there's been a significant decline for certain products. The UAE has some strategies that it implemented, like the Vision 2021 and also the Energy Strategy 2050, where they are saying they want to increase clean energy share from 25% to 50% by 2050. And then they are already implementing green energy strategies in support of their Vision 2021. So it is imaginable that in the UAE, domestically, they are not necessarily increasing consumption. They are doing more of production targeted at exports. But that remains to be quantified, to say how much are they exporting vis-a-vis how much they're consuming in-house.
All right, thank you very much. I don't see any other question that is coming through from the question and answer segment. What is left for me is to thank you for such an interesting presentation, and we look forward to the development of this work so that it can also contribute to policy and influence different sectors of the UAE's economy. Thank you.
Thank you.
We'll proceed now to our next presenter. I understand that Adetola Mabadeje Paul is not with us today, but rather the next presenter will be Providence Maburutse. Providence Maburutse. Providence Maburutse, are you there? Providence Maburutse. Right. We don't seem to have Providence with us. Just to check, Nina, do we have Providence? Or maybe we proceed to the next presenter. Maybe we proceed to the next presenter.
Reginald, I confirm that we do not have Providence.
Okay, we do not have Providence. All right, that's fine. Then we are going to the next presenter, Maslin Mora Aruya. Maslin Mora Aruya.
Wait, I will see if
Maslin Mora Aruya.
Not
present also. The only confirmed absence I had was
our Provice Chancellor wants to say something.
Okay.
Sorry to interrupt, Reginald. Thank you for this. I just wanted to say that in case that any of the two presenters are in the audience and they come up with a different name, so we cannot see the actual name, please raise their hand. Okay, so either Providence or Maslin. Okay, otherwise we will need to have, I guess, a break and then proceed with the last presentation, the plenary for today. But I think we can give them a couple of minutes at this point. Yes.
Thank you, Elena Moore.
I see actually Providence has joined.
Yeah.
Okay. All
Fantastic.
right. Give us a minute to promote her to panelist, and then she will be able to proceed, I suppose. Yeah.
Yeah, she accepted.
All right. Maybe let's just give a few more minutes.
Mm-hmm.
I can see that Providence declined. Oh, no, she accepted. Okay. Yes. Thank you.
Yes, yes. She's now part of the panelists. Yes, thank you.
Providence, can you hear us?
Hello, Providence. Providence Maburitse, welcome. Hello, Providence. Yes. Hello, Providence.
Hello.
Yes, welcome, welcome. Good to hear your voice. Welcome. Yes, welcome, Providence.
Hey, how are you, say?
I'm all right. Welcome to the UMC Conference 2024. Are you ready?
Yes, say I'm ready. Can you please put the presentation for me? I'm using a mobile phone.
All right. Thank you, Nina. All right, there we are. Now, Providence is presenting on microremediation of oil spills in Nigeria, and she has a focus on a cost-effective and environmentally friendly solution. Providence, you have 15 minutes to present. Thereafter, we'll ask questions and discuss with you for about 5 minutes. Over to you at this moment. Shall we proceed? Thank you.
Okay, thank you. So my presentation is on the effect of microremediation on oil spills, and I was targeting Nigeria. Microremediation is a cost-effective and environmentally friendly solution. My introduction. Oil industry is the largest and main generator of gross domestic product in Nigeria. And however, huge oil spills are negatively impacting the environment, social and economic activities of the country. The large oil spills are devastating and had outplaced all the cleanup efforts. The use of microremediation of bioremediation technology was seen to be the safe remedy, which is safe for the environment with relatively affordable prices as compared to other remediation methods. Okay, the problem statement and the purpose statement. It is estimated that more than 10 million tons of oil have been spilled to the environment over the past 7 years, but not more than 77% have been cleared. So, according to No et al. 2021, it can take up to 25 to 30 years to clean up oil pollution in Nigeria if 1 billion is used for the 5-year initial cleanup investment. So, Wilson et al. 2019 asserted that cleanup costs reduces profit of oil firms and close attention is needed to mitigate its adverse effects. And the findings of the study will be of importance to the established petroleum companies in Nigeria and other parts of the world, which can use fungi in clearing petroleum waste from their operation and also across their value chain. My aim of the study was to assess the effect of microremediation of oil spills in Nigeria economy and profitability of oil companies. my objectives. My objectives were to evaluate better types of fungi suitable for bioremediation of oil spills in Nigeria. The second one, to assess the effect of using fungi for bioremediation of oil spills on the net profit of petroleum companies in Nigeria from 2013 to 2022, and also to assess the effect of using fungi for bioremediation of oil spills on the economy of Nigeria from 2013 to 2022. Okay, the research questions. My first research question was, what are the type of petroleum degrading fungi? How does those fungi work in degrading petroleum products? How long does fungi take to clear waste? What are the benefits of using fungi in bioremediation and petroleum waste treatment to the economy of a country? And what are the benefits of using fungi in bioremediation and petroleum waste management on the profit of petroleum companies? Methodology and analysis. The content analysis research design was used to collect qualitative and quantitative data from secondary sources and the better types of fungi suitable for bioremediation of oil spills in Nigeria were achieved through assessing the fungi species with high degradation percentage within few days than other fungi species. Okay. The result illustrated that fungi can take at least 5 days to degrade 2% crude oil. Penicillium species were found to degrade a 95.4%, and Aspergillus niger degraded 75% of 2% crude oil. Then the Mocha species, this is the type of fungi, their highest degradation percentage, followed by the Penicillium species. The Aspergillus polypra and Penicillium communis have the lowest degradation percentage, failing to degrade at least 5% of the crude oil at low concentration of 1% after 15 days of incubation. Okay, the types of enzymes that were found to catalyze crude oil degradation. These include lignin peroxidase, lactase, manganese peroxidase, cellulase, lipase, dicolorizing peroxidase, peroxygenesis, cytochrome P40 monoxygenesis, fungal glutamine, fungal glutamine S transferases, NMC, macutanesis, and proteases. And these fungi have different functions which cooperate in the degradation of crude oil. And also the fungi also uses the non-enzymatic process. Besides the enzymatic processes, they also use the non-enzymatic processes. These non-enzymatic processes include the absorption of the toxic compounds on their cell, the biosignificant production, biomineralization, or bioprecipitation. Okay, so the results on the economic benefits of using fungi as a bioremediation process or in microremediation. This includes, we have the economic benefits, which includes the cost-effective. The use of fungi is a lower cost as compared to other remediation methods. And also it is environmentally friendly, and it is also versatile. You can use various enzymes to degrade pollutants, and also it is also adapted to high concentration of pollutants. We can use it to degrade so high concentration of pollutants, and it is also highly efficient since it can be also reused and can use also both enzymatic and also non-enzymatic processes. Okay. On profitability, it was shown, according to the data collected from various sources, it was shown that the error bars for micro-remediation costs and the remediation costs that were used by other oil companies to clean up my oil waste did not overlap, showing a statistically significant difference between the two remediation processes. Okay, in conclusion, the use of fungi species is prospected to completely clear the oil spills, making arable lands and aquatic environments clean for agriculture, forestry, and fishing activities. And also the remediation methods is cost-effective, environmentally friendly, recyclable, and very efficient, and it enables firms to align with SDGs of building sustainable cities and communities, which relies on safe levels of pollution while achieving to universal access to sustainable energy. And it will also have save companies from compensations and failure to clean up costs, hence cutting costs and maintain the net profit of oil companies. Thank you.
Thank you, Providence. Thank you, Madam, for a very interesting presentation and quite pertinent indeed, because we need these environmentally friendly solutions in order to address some of the challenges we have faced. I have one question for you that is of interest to all of us. As you look at your study, which are the two most important sustainable development goals that it addresses and why?
Okay. We have access to it. Also addresses climate change and clean environment.
Go ahead.
And also clean environment.
All right, thank you very much. We also have another question from the platform, which is highlighting, have we not mixed partially the problem statement and the study results? Would you want to unpack this one? Have we not mixed the problem statement and the study results partially?
Problem statement and the study results on the presentation.
Yes, on the presentation. Would you want to just highlight again the problem statement so that you differentiate it from the results? Thank you.
Okay. Okay, can you please go back to the slide so that I can do it?
Okay, all right. Maybe let's ask Nina Moore, please assist with the problem statement slide. All right. All right. So the question says, have we not partially mixed this problem statement with the findings or the results of our study?
Okay.
Yes.
No, I didn't. I just took this from the literature as a problem so that I can find other remediation processes that can help to solve this problem. So I don't think I've made the two.
All right, thank you very much for that clarity. Now, another question, which will be the last one, because you actually did present well on time, and you had 3 minutes ahead. Another question is, why fungi as compared to other alternatives for rehabilitation, particularly in the context of Nigeria? Thank you. Why fungi?
Okay, I actually chose fungi because it is adapted to a variety of environmental conditions, and it can be also reused. It can also make use of both enzymatic and non-enzymatic. We can make use of like a filamentous fungi, which can absorb the pollutants into its hyphae and break down into non-toxic components. So fungi might be a better choice as compared to bacteria. And most of the fungi, they can be seen and less harmful as compared to bacteria. They are so microscopic and we cannot see them with our naked. So fungi, we can easily even grow them on the polluted area since they can grow in a variety of environments. So we can even grow them on polluted areas. They will be using their both non-enzymatic and enzymatic a mechanism to break up the pollutants. So a fungi can be reused, easy to manage, and also cheap as compared to other microorganisms.
Right. Thank you very much, Providence. I don't see any further questions coming from the audience, and all I'll do is to thank you for an interesting presentation, and we have learned quite a lot from your study title and presentation. Thank you for that opportunity. Chair, just to check. You're welcome. Chair, just to check if we have another additional candidate who's...
Reginald, actually, the next presenter is not in the meeting.
All right.
We proceed into having basically a larger break than we were supposed to have. We should take a break and we'll be back at 3 o'clock to have the final plenary presentation for today's session by Dr. Kezia Njoroge, and then we will close the meeting for today. So I will see you all at 3 o'clock.
Dear colleagues and attendees, welcome to this session. I can see that we have our final presenter for the day. Okay, this is Dr. Kezia Njoroge. I hope I'm pronouncing the name correctly. If I'm not, please correct me. Okay. I would like to also give the floor to Yanis Loga, who's going to chair this session. So Yanis, would you like to take the floor?
Yep, thank you very much. I don't know if you can hear me. Just to make sure before we start. Thank you. Okay, so thank you very much, Dr. Bulum. So yeah, my name is Yanis Luka, and I'm the program leader for the School of Sciences, Health, Technology and Engineering at Unicaf. And it's my great pleasure to introduce our next speaker, Dr. Kezia Njoroge. She's a senior lecturer in public and allied health at Liverpool John Moores University. And Dr. Njoroge's research focuses on the important yet often overlooked public health issue, the practice of clay ingestion, or geophagy, among African migrant women during pregnancy in London. So her work explores the cultural significance of this practice and the potential health risks it possesses, while also offering critical insights into how public health interventions can be designed to address this in cultural sensitive manner. So Dr. Njoroge, please, can't wait to hear your research. Thank you.
Thank you, thank you for giving me this chance to present. I'm trying to get my PowerPoint on. You let me know if you can see it. And yes, Dr. Elena, you pronounce my name right. I hope I'm pronouncing yours right as well.
It's correct. Thank you.
Yeah, thank you. You can see my screen?
Yep, we can. That's perfect. Thank you.
Okay, thank you very much. So my presentation is on experiences of geophagy during pregnancy among African migrant women in London and looking at the implications for public health interventions. The term geophagy is the compulsive consumption of earth, dirt, or clay, and therefore clay ingestion is part of geophagy. And clay ingestion among pregnant women is a major public health that needs attention, especially in regard to the goals and the SDGs, and referring to goal number 3, which aims at ensuring healthy lives and promoting the well-being of all, therefore pointing to the need to focus on the clay ingestion among pregnant women and looking at the risks that it poses to the women and the child that they are carrying. The background: clay ingestion by pregnant women can be toxic to the human body, and research has shown that it has some lead and arsenic in it. This has also been shown by research to cause low birth weight in children, impaired intrauterine development, and intestinal blockages. Research has also shown that the lower levels of exposure to lead can affect brain development, which has implications for intelligence quotient and attention span reduction, antisocial behavior, and reduced education attainment later in life for the child whose mother injected clay that had lead. And this is referring to lower levels of lead. The issue or the subject of clay ingestion is mostly affecting the middle and low income countries, but it also affects the high income countries, which have shown evidence of high rates of low birth weights, according to UNICEF 2023. The Black ethnic groups have the highest infant mortality rates for low birth weights, babies, and this group is followed by the Asian ethnic groups, where we've seen high infant mortalities for the low birth weight babies. Women from the Black ethnic groups in the UK are also known to experience poor maternal health outcomes, according to the Office of National Statistics, ONS 2021. One of the contributing risk factors, as we shall see in this discussion today, is clay ingestion. Clay ingestion practice is seen as a cultural practice during pregnancy and is widely practiced in Africa. There is evidence of clay ingestion among African migrant and Asian women in the Western context, especially here in the UK, by a study by Matsiva and Chinoya 2023, which was done in the UK, was able to give this evidence. The UK Food Standard Agency, that is the FSA, issued several warnings against clay ingestion among pregnant and breastfeeding women, as well as restrictions on clay sales in 2022. The Public Health England as well, which is known today as the UK Health Security Agency, that is UKHSA, also notified public health practitioners to dissuade women from ingesting clay. That is when the women visit the hospitals for antenatal care, then the public health practitioners were notified to dissuade these women from continuing with clay ingestion. Despite these efforts by the Public Health England and the UK Food Standard Agency, the women have continued to ingest clay, and the sale of clay has also continued under the counter. The purpose of this study was to understand the women's lived experiences as they navigate pregnancy, and this was to be informed by their cultural framework on clay ingestion. This is crucial for informing public health practitioners' engagement with women, both in their clinical encounters and also outside these clinical encounters. So the purpose was to give this information that we collected and inform the public health professionals and probably forge a better way of engaging with women during their antenatal care. The methodology that were used were in-depth interviews where 30 women were interviewed remotely. This took 62 minutes, maximum 60 minutes with each participant. The participants were between 29 to 49-year-old. 2 African community mobilizers were trained to recruit these participants. And after they recruited, they were used because they were already known to the community. And so they were trusted and they were able to enhance the rapport between the researchers and the participants. After they were recruited, the researchers then contacted the recruited participants for a briefing meeting. This meeting allowed the participants to ask questions about the study before agreeing to participate. Purposive and snowball sampling methods were used to recruit the participants. The inclusion criteria, the participants had to be self-identifying as Black African or Africans. They had to be over 18-year-old. They had to be living in London Borough in the UK. They should have experienced clay ingestion during pregnancy in England in the last 10 years. The findings, the women clay ingestion experiences emerged in 2 broad themes. One being what our communities say about clay ingestion during pregnancy. And the second one was experiences of clay ingestion during pregnancy. The sub-themes were clay ingestion being a widely accepted practice, or the findings showed that clay ingestion is a widely accepted practice. Then another sub-theme presented as childhood and social networks around the clay ingestion practice. The third sub-theme was clay preferences, safety, and beliefs. And the fourth one was clay ingestion reasons, frequency, and quantities. We are going to, I'm going to present the 4 sub-themes and the quotes that go with these sub-themes. So the first one is clay ingestion as a widely accepted practice. So the findings, or what the women told the researchers, was that clay ingestion is a normal and a widely accepted practice. They refer to it as a culture, as a tradition, with family and community members actually enabling the practice. In addition, they told us that the clay ingestion had nutritional benefits to them and the child that they were carrying. These findings resonate well with other findings. For instance, a study conducted in Uganda, a neonatal study, showed that 80% of these women had practiced clay ingestion during their pregnancy, according to Kalanzi and others in 2013. Another study that was conducted recently in 2021 reported a 45% clay ingestion practice among 307 women who were attending an antenatal care. The participants in this study they reported clay ingestion to be synonymous or to be a practice that go along with pregnancy. And this also concurs or is reflected in other literature, such as what Shinondo and Mikuma, their studies in 2008 reflects the same, that clay ingestion is perceived as synonymous with pregnancy. These are two of the quotes that reflect clay ingestion as a widely accepted practice among the participants who participated in this study in London, UK. One of the mother describes clay ingestion as an acceptable, well-known practice in her culture and explained it this way. In my culture, when you're pregnant, it's like clay is supposed to help you with pregnancy. I would say it's a known thing. I know it is an accepted thing. For instance, if I went somewhere and I'm craving for it, they will bend over heels to find me some. It is not a taboo. This was an Ugandan mother that told us this. Another one told us it's a normal practice and it's also a sign of pregnancy. So she said, back home, it is very normal when you see someone eating clay, then you're like, oh yeah, I think you're expecting. It is something that's expected when you're pregnant. This was by a Zimbabwean mother. The other women were able to show that this practice is acceptable and it had perceived benefits. Some of them talking about this practice being a mineral supplement for the pregnancy, according to the one mother from Zimbabwe. The last mother from Ghana said that it gives a bit of iron, it gives me energy, it prevents me from vomiting when I'm pregnant, and I vomit a lot. The second sub-theme, childhood and social network. The participants in this study experiences of clay ingestion. They were able to show us that this clay ingestion practice was started during childhood through observations. They were able to observe either a mother, a grandmother, practicing clay ingestion. And so they started testing, or their testing experiences started when they were on errands to fetch clay up. And this also resonates or agree with another study by Dico and Dico 2013, which showed that children were practicing clay ingestion as they went on errands to fetch clay for their mothers or their grandmothers. Another study in Kenya showed that out of 378 pregnant women, clay ingestion was seen in young girls. Another study among Zambian school children showed that 79% of these children who ingested clay had more relatives who practiced clay ingestion than those children who didn't engage in the practice. So the conclusion is that they may have learned from their relatives how to engage in this practice. Participants who participated in clay ingestion during childhood, in this study that was done in London, they reported stopping this practice in adulthood, but engaged again when they became pregnant. The study findings in London showed that, or has shown us that, the family played a very powerful role of influence or social influence, and they acted as the first agent of socialization in enhancing the clay ingestion practice. Participants who did not use clay ingestion practice in childhood in this study conducted in London, they reported receiving recommendations from family and friends to engage in it when they complained of nausea and vomiting. These are some of the quotes to go with it. I'm only going to take the last one. One mother explained it this way. I thought if you're pregnant, you have to eat clay. But I ate clay when I was younger, but I hadn't eaten clay for ages until I became pregnant. I was like, nope, you can't be pregnant without eating clay. In Africa, a lot of women ate clay. Some would say they ate it for spitting, for this, for that. But for me, it's like you have to eat clay if you're pregnant, because I just associated it with pregnancy. This came from a Cameroonian mother. The third sub-themes that came up from the findings in this study is the clay's preferences, safety, and beliefs. The participants in this study, they reported that the clay that they used was processed, and some used unprocessed clay. Most of the participants in this study preferred unprocessed clay, which is natural or plain. Why? Because it was safe and risk-free to them. The clay preferences were also informed by countries of origin, with some participants from Ghana and Congo talking about clay that was salted and molded into finger-like shapes. Participants from Zimbabwe, Cameroon, South Africa, and Uganda, they reported to be ingesting an unprocessed clay. Some of the participants reported ingesting clay directly, like sweets or chocolates. Others, they mixed their clay with herbs and took it as a drink. Others reported taking a grilled and baked clay, which improved texture and smell, and this was very important to these participants. This resonates well with some studies. A study by Shinondo and Mikuma, 2008, reports that roasting or clay baking was reported to improve its smell and taste, as well as kill off helminth and parasitic, and this was meant to ward off parasitic infections. We also have a large body of evidence from quantitative studies that show that clay ingestion is linked to helminth infections during pregnancy, with incidence of infection at 20%, as reported by these authors. Another one reports 51%, and another one reports 71% of these incidents. These are some of the quotes. I'll just take one. The last one of the mothers from Uganda said that, I like the traditional one, the plain clay, no sugar, no nothing. It needs to be darker clay, but quite hard, not soft, hard enough to bite it. I never liked the soft one. Of course, it has to smell good. I have to smell it before I eat it. They have different smells. I would know from the smell that this one is not the one. If you want to make it better, when you get it, put it in a foil, paper, and charcoal grill it. The third sub-themes is on clay ingestions, reasons for clay ingestions, the frequency of clay ingestions, and the quantities. So the participants in this study reported taking clay religiously every day, 3 times a day. Others said all the time. Others talked about ingesting clay like food. Others said they ingested clay over and over again. And others talked about twice a week. Others said too much, can't quantify, can't say how much, the size of a bowl. Others said I took 1/2 to 3 1/4 kilos of clay. Others talked about having clay in the morning or fasting in the morning, last thing at night. Others talked about carrying clay to work as a snack. Others talked about sleeping with clay in the mouth to avoid waking up to spit. Others reported sleeping with clay under the pillow for easy access at night. The availability and unavailability of clay also influenced the frequency and the quantities. When there was scarcity or they couldn't find a place to eat, then they ate the clay sparingly. 24 out of 30 participants in this study, they cited eating clay to avoid nausea, vomiting, and spitting, as well as increase appetite as the reason for clay ingestion. So some studies resonate with this sub-theme. with others studies showing that ingestion of clay by participants was 100 to 400 grams per day. These are some of the quotes. I'll just take the last one. One of the women from Zimbabwe said, in a day, I would eat maybe half a kilo of 3/4 because remember, it was helping me to boost my appetite. And my mom always said it helps me to give a healthy baby. So who doesn't want a healthy baby? I religiously was taking this clay. So that those are the themes, the sub-themes that I've presented today. So on conclusion and recommendations, we can see that there is lack of relevant knowledge and risk awareness among the participants. There is the projection that they believe that clay is safe because their ancestors ingested them or their mothers or their grandmothers ingested them for generations without evidence of harm. Therefore, intervention should go beyond individual or pregnant women, especially pointing to the role of family and friends, the community, and the social networks, which cannot be ignored in the interventions. There is need for innovative and culturally sensitive interventions. Then the study also points out the role of nutrition in pregnancy and the inclusion of clay ingestion and the health risks that go with it should be put in the messages that are given in maternal health nutrition information. There is need for further research to assess the ingredients of the processed clay, the health implications, and the prevalence of clay ingestion in the Western context, including the UK. There is also need for multi-level interventions which target all levels of influence on women clay ingestion behavior up to the policy level. Thank you very much.
Thank you very, very much, Dr. Njoroge. That was very insightful and very informative. So now we have some time for some questions, if you don't mind. So I was wondering if there was any particular toxins or harmful substances identified in the clay or like bacteria or something, if you could share that with us.
Yeah, thank you. Is it Mr. Luca? Thank you. This study did not go to the stage of actually looking at the contents in the clay, and that's why in our recommendations for further research, we would like to look at the contents that are in the clay. However, past research have shown that there is some lead, arsenic, and some other toxic metals have been found in clay. So there could have been those kind of metals in the clay that the women were ingesting since they had not been approved by the UK food regulations.
Okay, thank you. Also, how do you think your findings will influence maternal health in the UK? Do you think it will affect it in any way?
Yes, I believe this study has been disseminated through the journals, and we are also hoping that in the future we could engage the health professionals and the health sector in conducting interventions that will, as you can see, the Public Health England is already aware that women are ingesting clay, but the warnings that they've given and the notice that they've given hasn't worked because the women have continued ingesting clay anyway. And another analysis that we are doing at the moment in the same results that we got, we can see that the women are not disclosing to the professionals, the health professionals, when they attend the antenatal care. So when we conduct an intervention, we hope to involve the health professionals, and probably they'll be able to address the matter in a different way and help the women see the risks that they are engaging themselves in by clay ingestion, and hopefully find a solution to the practice.
Thank you for that. I was also wondering if, like, do you think the migration experience from Africa to the UK, like, intensifies or alters the practice of geophagy?
Yeah, the practice is among the same. The migrant women, they have practiced them where they're coming from, so they've only transferred the practice to the UK. They've only continued with what they know to do, and we assume that in the past we did not have a lot of pollution. The climate was better. We know that the climate has changed, and probably the clay was much cleaner than it is today. So, of course, with the pollution that is being reported, the clay could be more toxic than it was that time. And we also feel that they are influencing other women who have not practiced, because when they've migrated with the practice, they are able to pass it on to other women who've never practiced it. So yes, we are envisaging a situation where it's actually, the migration is actually enhancing the practice and spreading it further.
Thank you very much. We have a few questions from the participants as well. So one of them is if there's a possibility of getting another derivative in place of clay.
Yes, I'm assuming that the question is asking if there could be a replacement of that. Yeah, and what we've proposed is that if the Public Health England is able to actually make this clay safe, because the women are still continuing with the practice, the women are still buying the clay under the counter, so we still have people who are bringing it to the UK and selling it under the counter. And our suggestion was, if this clay could be made safe so that it is regulated and the safe one is allowed for sale, then the women would still have this clay, but it is a clay that has been processed properly and the toxics have been taken off it. And of course, we have some of the women were taking clay because they were craving for iron, or they needed iron. And when they were given iron tablets, they vomited more, and that's why they resorted to having clay. So the iron or the solutions that were being provided in the hospitals were not dissuading them from taking the clay. So that's why we suggest that if the clay was made safe and regulated properly, probably then it would drive the practice that would cause more risk to the pregnant women and the mother down.
Thank you very much. We have a few more, if you don't mind.
That's fine.
So one is asking if you can expand on the findings regarding children and any possible future studies and recommendations.
We did not carry this study with the children. We carried with the mothers, and most of the mothers defended the practice by saying, "My children are normal. There's nothing wrong with the children." But as we did our research and looking at what has been done in the past, some of these effects on the children could be long-term. They may not have been seen now, but they could be seen in the future, or carried on to the future generations of these children. We haven't thought of taking the study with the children, but we plan to just do an intervention with the women, but hopefully in the future we might think about conducting the study with the children as well.
Thank you very much. And one last question for me. I know this doesn't really, maybe it's not part of your research, but if you're aware of any other practices similar to geophagy, or if you know any other communities that partake in geophagy apart from the African communities.
Yes. Yes, thank you. I'm not aware of any other practice for the pregnant women or that has implications for maternal health. But there are other communities. We only conducted this study based because of the resources that we had with the African migrant women, but research is showing that the Asian communities as well is practicing. And we also have other migrant women from other countries are also practicing. So it's not just the African women, but we hope that these results from the African women could be used to help all the other communities. Yeah.
Thank you very, very much. I think that's it from us. Thank you very, very much for the wonderful presentation. I think it was very insightful for everyone who was listening. And yeah, thank you very, very much.
Thank you for having me.
Thank you. Have a lovely day.
Thank you. Thank you so much.
Bye.
Thank you very much to Dr. Joronje for the presentation, and of course to Yanis for the chairing of this session.